All right, a very good morning, distinguished ladies and gentlemen. It's my pleasure to warmly welcome us to this auspicious occasion. We warmly recognize the presence of all dignitaries in the room, and to kickstart the proceedings formally, may I kindly request that we get ready to have the national anthem, the opening prayer for us as a country is the second stanza of our national anthem. So for those who are just getting to know. So we just kindly request that you rise to our feet. Then we take the second stanza of our national anthem, which is our opening prayer for this event. Media, please. Director General, Nigeria Center for Disease Control, Dr. Ifedayo Adetifa. The Country Director, United States Center for Disease Control, Nigeria, Dr. Mary Boyd. The directors of ministries, departments, and agencies of government here present. Dear national observers to this great event, the external evaluators we are glad to have in our midst. A very distinguished partners who have been with us all through the work. Gentlemen of the press, very distinguished ladies and gentlemen. It is my pleasure to formally welcome us to this great event, the second joint external evaluation for Nigeria. It might interest us to know that Nigeria has become the third country in the series to have been able to conduct a second joint external evaluation. And I think to this we deserve a round of applause. It's been a great progress made since the last JEE conducted. And so we are gathered here today to take us through what we've done, how far we've gone, looking forward into the days ahead. But just a bit of housekeeping before we move on in this event. For our comfort, please, the door to this side will be shut. If we need to exit the hall, it's through the back except for the dignitaries in the front row. And if you need to use the convenience just to the right, when you come out of this hall, we have the convenience there for us to access. And in case of any emergency, all the doors will be open for exits. Moving on in this event, apologies, let me cross-check this is working well. Hello? All right, I think this is better. Thank you very much. So it's next on the agenda is for us to receive the goodwill messages from our very distinguished partners on this journey. I believe we have the representative of our distinguished partners in the room. And so it will be my pleasure. Can I cross-check first from Dr. Me if the WR is going to be doing this, or you stay yourself? Great. Thank you very much. So on behalf of the World Health Organization, Nigeria office, I'd like to receive to the microphone for the goodwill message from the World Health Organization, Nigeria office, Dr. Me Okamura, the EPR lead for WHO in Nigeria, for the goodwill message. A round of applause for Dr. Me, please. Go and give her the mic.
Thank you. DG and CDC, distinguished partners, government officials. I'm standing here on behalf of WHO Country Representative Dr. Walter Kazadi Mulombo. Let me take this. It is with a great pleasure that I especially welcome you all, government personnel, policymakers, partners, and stakeholders to this historical event, Nigeria's Joint External Evaluation Workshop. As many as here already know, the GEE is a voluntary, collaborative, and multisectoral process that allows countries to assess their capacities to prevent, detect, and rapidly respond to public health risks. Through the GEE, we can identify the most critical gaps within our health system across human health, animal health, and other relevant health sectors. This, we believe, will help us prioritize opportunities for enhanced and effective preparedness and response to public health threats. Since its establishment as one of the 4 IHR monitoring and evaluation frameworks, WHO has been supporting its implementation across several countries worldwide, including Nigeria. Also, hello? Also, the GEE tools itself has evolved over time, bringing in lessons from COVID-19 and providing us with more insights and context to guide us in effectively evaluating the progress we have made together as a country. We know and applaud the hard work that country stakeholders have put in over the last 5 years since the last official GEE to address the health system gaps which were identified. WHO is very happy to have been a part of several health system strengthening activities to enhance the country's preparedness and response mechanisms to public health threats. Furthermore, we recognize the amazing efforts and work that the country planning teams has out in to make this event a reality. Right from the planning and implementation of the self-evaluation workshop up until the currently culmination to the external evaluation, the planning team has shown dedication to ensuring the success of the GEE. Finally, I would like to especially welcome the external evaluation team who have taken some time out of their busy schedules to provide Nigeria this important technical support and expertise for the GEE. Thanks you all. Thank you for all you do, and we look forward to receiving the best from your support. Now, the GEE presents another milestone opportunity for us to celebrate our achievements, reflect on our gaps and weaknesses, and commit to working together collaboratively for improved public health preparedness and health system strengthening. As we proceed the final process of this evaluation, I encourage us to continue to be thorough and candid so we can give the most appropriate evaluation of our country. In all this, WHO reinforces its commitment to support this important GEE process and the subsequent results and action points. I wish you all a productive deliberation and evaluation exercise. Thank you.
Thank you very much, Dr. Mio Camera. For the goodwill message on behalf of the World Health Organization. Very much appreciated. Right, moving on, the list of the very respected partners providing goodwill message in support of this great event. It's my pleasure to warmly receive to the microphones the US CDC Nigeria Country Director, Dr. Mary Boyd, for the goodwill message. A round of applause for Dr. Mary, please.
Good morning, everyone. So our JEE external evaluators, you're very welcome to Nigeria. Colleagues from the diplomatic community for health, implementing partners, WHO rep, Nigerian leadership, led by the DG NCDC, ministries, departments, agencies, all present, members of the press, distinguished ladies and gentlemen. On behalf of the US government, it is my absolute pleasure to be here today and be part of Nigeria's second JEE. The US government remains invested, recognizing that public health threats abroad have great impact on Americans at home. Epidemics over the last 2 years show that indeed we need to do more over the last 2 decades. We need to do more to ensure that countries have the capacity to prevent, detect, and rapidly respond to public health threats, to protect people across the world, because we are all connected, and therefore we need to approach it in a collaborative manner. Working together to prepare for outbreaks before they occur means that there are smaller or less outbreaks, there the money saved, and most importantly, that lives are protected all over the world. And the JEE, or Joint External Evaluation, is an important example of such a collaboration. It ensures that there is a collaborative approach between our country experts as well as external evaluation team. It examines the capacities across multiple technical areas so that countries can have a measurable means of following progress. For Nigeria, we all have high hopes for the score, but I think what's even more important is that it will help us identify what we need to work on. So I just wanted to say that CDC, on behalf of the US government, remains heavily engaged and invested. And I wanted to also just end by saying that we're in it together. Whether it's a high score or low score, all of the scores matter. And we look forward to seeing ways that we will engage even more strongly. Thank you.
Whether high score, medium score, or low score, we are all in this together. A round of applause for Dr. Mary Boyd for the US government. Very much appreciated. Thank you so much for all the support. So far, so good. All right, moving on in Same order. Can I confirm if we have the representative of FAO in the room yet? Okay, so while we wait for the representative of FAO, Nigeria has benefited tremendously from the World Bank support in the last couple of years. It is my honor and privilege to welcome senior health specialists for the World Bank here in our midst for the goodwill message. Distinguished ladies and gentlemen, please make welcome with us Dr. Mike Olugbele. A round of applause for Dr. Mike, please.
The DG of NCDC, external evaluators, partners, distinguished participants of this event. On behalf of the World Bank, I'm very pleased to be here to give this goodwill message. As you know, after the Ebola outbreak of 2014-2015, development financing institutions started paying more attention to health security. And the World Bank, in a bid to actually strengthen the capacity of countries in developing countries for them to prevent, detect, and respond to outbreak, started the REDISE project. The REDISE project is the Regional Disease Surveillance System Enhancement Project, a health system strengthening project. Of course, with any system strengthening project, you don't expect to see immediate results, quick results. And that's why the bank, for us to be able to evaluate the progress that have been made with the investment through REDISE, we chose to use the JEE indicators as our result framework, meaning that we set ourselves up to show whether we are going to achieve results or not at the end of the day. And we are very pleased to say that even as REDISE is coming to an end later this month, this second JEE will provide useful results for us to see what progress we have made from the baseline, from the first JEE and now. And that's why this particular event is very, very important to us. But more importantly, from the internal assessment that has been done, of course, we know that our external evaluators will validate our scores. I'm sure it's not going to be low score. It's going to be, it might not be the high score, but the truth of the matter is that we might not be where we want to be yet, but definitely we are not where we used to be. From the initial 39% that we had at the baseline in 2017, I'm really looking forward to the external evaluator validating the significant progress that we have made in the last 5 years. And from the World Bank, we can be sure that even as REDISE is ending this month, the bank is not leaving. We're all aware of the pandemic fund, and currently the bank is also preparing a preparedness project for countries in developing countries. And even in Nigeria, we also have a COVID-19 project, the corporate project, that will particularly be supporting, strengthening the capacity at the subnational level, the health security capacity at the subnational level. So the bank is here to continue to support us. So we look forward to the gaps that will be identified through this evaluation. And then, of course, more importantly, the National Action Plan for Health Security that will be developed so that we can help the country to continue to build and strengthen its capacity to prevent, detect, and to respond to outbreak. So on behalf of the World Bank, I'm very pleased to be here, and we will be continuing to support the country, and I wish all a very fruitful deliberation. Thank you.
It's gratifying to know that even though REDISE ends, the bank is not ending. And so more continuous support is guaranteed and assured. It sounds very good to our ears. Thank you so very much, Dr. Mike, for all the World Bank is doing for the love of the country. Moving forward, it's my pleasure to receive from the Kingdom of United, The United Kingdom Health Security Agency here represented. It's my pleasure to welcome the Country Director, UKHSA, Dr. Shola Aruna. A round of applause for Dr. Shola Aruna, please.
Director General, Nigeria Center for Disease Control and Prevention, do permit me to stand on existing protocol. On behalf of the UK Health Security Agency's International Health Regulation Strengthening Project, I would first of all also like to welcome the external evaluators to this very important 5-day meeting. The UK Health Security Agency's International Health Regulations Strengthening Project has been invested heavily in the strengthening of the core capacities of Nigeria over the past several years. We have been part of the journey right from 2017 with the first JE. I see Richard nodding his head, absolutely. And we were also heavily invested as well in the development of the resulting National Action Plan for Health Security following that. Not only that, the midterm country-led evaluation in 2019, we were also very much engaged with that. And that just shows how important we see this 5-day process. We have also been quite engaged with the self-assessment and hoping that all the work that's been done over the years will be validated by the external team. Not only just validated, but also pointing us in the right direction in terms of the gaps, in terms of the opportunities, apart from the successes that we've had. We will continue as the UK Health Security Agency's International Health Regulation Strengthening Project to be involved in the outcome of this evaluation in terms of identifying areas where we will be able to use our strengths and our relative advantage to support Nigeria in further strengthening its core capacities of the IHR. And why is that? Because we believe that we are stronger together. On that note, I wish us all very fruitful deliberations for the rest of the day and the rest of the week. And we look forward to the outcome of the external team. Thank you.
Thank you very much, Dr. Shola Aruna, on behalf of the UKHSA International Health Regulations Strengthening. Just a couple of goodwill messages before we go to the presentations. Crave your indulgence. It's my pleasure, distinguished ladies and gentlemen, to receive the goodwill message of Africa Center for Disease Control representative here in the room. The Africa Center for Disease Control is heavily represented here by Dr. Chioma Dan Huwanfo, who will be bringing forward the goodwill message on behalf of Africa CDC. A round of applause for Dr. Chioma as she makes her way to the microphone, please. Sorry, she's sitting on the far distance. She needs to make her way. You know, ladies don't rush, so they take their time. So it's well understood. You're welcome, Chairman.
DDG and CDC, external evaluators, distinguished partners, ladies and gentlemen, good morning. As we transition beyond the acute phase of the pandemic to a long-term integrative sustainable control strategies, the JEE 2.0 is timely, is laudable, and is a step in the right direction. On the continent, Nigeria is one of the few countries that have achieved this great feat. We commend all stakeholders for the efforts and resources invested in this voluntary evaluation using the One Health approach. Beyond the national evaluation, Nigeria has conducted the sub-national health security assessment to further ascertain Nigerians' health security. As we build back better, Africa CDC is committed to strengthening continental health security by supporting national public health institutes to build capacity and capability to detect, respond rapidly and effectively to disease threats and outbreaks based on data-driven programs such as the JEE. On behalf of the Africa CDC team, I wish us a fruitful evaluation, and we're looking forward to more collaborative partnerships to support the outcome of the evaluation. I thank you.
Thank you very much, Dr. Choma Dan Wafo, for the goodwill message on behalf of the Africa CDC. Still in Africa, it's my pleasure to recognize and receive to the microphone the representative of Africa Field Epidemiology Network, very committed, distinguished organization supporting workforce and human resource development for public health in Africa. Speaking for Nigeria office, distinguished ladies and gentlemen, please make welcome the Regional Technical Advisor, Dr. Patrick Ngoko. A round of applause for Dr. Patrick, please.
DG, NCDC, our external evaluators, representatives from ministries, departments, and agencies. Allow me to also stand on existing protocol and really say that this is a historic moment for Nigeria as we embark on the second JEE. I think the internal evaluation, validation, and the discussions about strengthening our systems will be more important even as we give specific scores to the various technical areas. Allow me to say that as AFINET, we have worked very closely with NCDC and our main partner, the US CDC, on workforce, which is the engine of preparedness, detection, and response. Allow me to say that even as we finalize the JEE, the second JEE, and get quickly to the process of developing a national action plan and looking for resources to actually do the real work, I think there are a lot of lessons, there are a lot of considerations to make. One of it being the constricted physical space, globally but also nationally. The conflicts that we are experiencing, but also the many lessons that we've learned as we implemented the first national action plan. So I hope that even as we go through this process, we will learn from what has transpired in the last 6 years, and that we'll focus, as other speakers have said, on the efforts subnationally, so that even as we attribute a score nationally, there's a lot of focus on the subnational and community level. So I also join others to wish us a successful second JEE, and what the future looks in terms of strengthening health security as we move forward. Thank you very much.
Thank you very much, Dr. Patrick Ngoku, for all you do and for the organization's efforts in Nigeria. Very much appreciated. Moving on, distinguished ladies and gentlemen, it's my pleasure to recognize, now coming to West Africa, the West Africa Health Organization representative in the room who will be bringing forward the goodwill message on behalf of WAO, a distinguished epidemiologist of repute. Ladies and gentlemen, please receive with me Dr. Islamihat Olatinwo. A round of applause for her, please.
To all the distinguished dignitaries and colleagues, everyone, ladies and gentlemen, aligning with the existing protocols, I bring greetings on behalf of ECOWAS RCSDC and WAO. I welcome everyone to this momentous occasion of the second JEE, which is a collaborative multisectoral process to assess a country's capacity to detect, prevent, and mount response to a public health risk being conducted here in Nigeria today. It is indeed an honor and privilege to be here as we gather, united by a shared commitment to safeguarding global health security. Through this, we will not only strengthen our preparedness, but also the region's capacity at the entire international community. On behalf of WAO and ECOWAS RCDC, I wish everyone a fruitful deliberation. May the discussion that followed be insightful and the outcomes achieved be far-reaching. Thank you.
Thank you very much, Dr. Islamihat, for the goodwill message from WAO and ECOWAS RCDC. With particular emphasis on the One Health collaboration we have enjoyed, having come this far, external evaluators, distinguished ladies and gentlemen, it's my pleasure to welcome the representative of FAO in the room, Food and Agriculture Organization, ably represented here this morning by Dr. Just a second. You know why I need to talk all the name very well because it's a special name. Dr. Otto Muhinda. A round of applause for Dr. Muhinda, please.
Thank you very much. You did well. Those names from East Africa are not easy. Good morning, everyone. I'm here to represent FAO in Nigeria. And I wish to say that we are very glad that we are engaging in this second GEE, which we value very much. I want to thank everyone for being around, and also to welcome you to this process that is with very high importance. FAO have been working in very important areas of the health security, being the workforce development. We are also working on the surveillance of animal and zoonotic diseases. We also work around the development of laboratories and the strengthening of the mechanism that support laboratories to be accredited. We have already supported around 21 labs in the country. We are also very much interested on microbial resistance. So far, we have collaborated on this, and we hope that the efforts put so far have been achieving a high score for the first GEE. And we expect to continue to work together with all of you for the best Nigeria. Thank you very much.
Thank you very much, Dr. Hoto Muhinda, for all you do. Dr. Hoto is the FAO ECTAD team lead for the country. Very much appreciated. So we still on the One Health interventions and the support we have received so far with the collaboration with our sister ministry. It's my pleasure on behalf of the Federal Ministry of Agriculture and Rural Development in Nigeria. Ladies and gentlemen, please make welcome the Deputy Director of HEFMAT, speaking for the ministry, Dr. Salome Bawa. Is Dr. Salome in the room? Oh, sorry, she's sitting at the far distance. Let's appreciate her. She makes her way to the microphones, please. Thank you very much, Dr. Salome. You're welcome.
Good morning, everyone. I would like to align on existing protocols and read the opening remarks by the Chief Veterinary Officer for Nigeria, who is unavoidably absent because of exigencies of duty. It gives me great pleasure to be here with everyone at this second joint external evaluation for Nigeria. The emergence and re-emergence of infectious diseases globally has necessitated the need for countries to improve capacities for prevention, detection, and response to global health threats, support global disease control efforts, and improve health security. The Nigerian government, in particular, has recognized the public health impacts of conducting a joint external evaluation. This exercise has challenged and encouraged actors in the global health security space to work concertedly and collaboratively with one goal, and this is commendable. It may interest you to know that Nigeria has grown in her capacity from the first JEE, and we believe that with a strengthened One Health collaboration involving relevant stakeholders, we will achieve more and go to greater heights. At this juncture, let me, on behalf of the Federal Ministry of Agriculture and Rural Development, thank all for attending this evaluation. I assure you of the ministry's willingness to collaborate and partner with you on this and similar exercises. Thank you and God bless.
Thank you very much, Dr. Salome, for bringing forward the goodwill message and for all the support from Federal Ministry of Agriculture and Rural Development. Very much appreciated. The Director General, Nigeria Center for Disease Control. Distinguished ladies in the last 5 years, we've made significant progress. External assessors, evaluators, observers, distinguished partners. It is my pleasure to now bring forward to speak to us on the overview of the country's national health system, public health services, and health security system, speaking us through how far thus far, the progress we have made. Can I confirm that we can take 1 minute before we get into that? Okay. All right. So just a minute, please. Yeah, my attention has just been called to the fact that I actually cross-checked earlier. Do we have the Federal Minister of Environment now in the room? Representative? Yeah, I confirmed earlier that they are not here, so we can move on. All right, but we appreciate that we acknowledge their support. They were around during the internal assessment and made significant contribution to this process. Now to formally welcome us, and before he takes the presentation, the overview of the country's national health system. It's my pleasure to welcome the Director General, Nigeria Center for Disease Control, in person of Dr. Ifedayo Adetifa. A warm round of applause for the DG as he makes his way to the microphones. The Director General, please. You're welcome, sir.
Well, good morning, everybody. And because there are going to be a lot of speeches today, permit me to skip protocol and dive right into welcome. I am particularly honored today to welcome you as we begin the journey of Nigeria's second joint external evaluation. The next few days signify an exceptional moment in our ongoing commitment to safeguarding the health and well-being of Nigerians, and in turn, the sub-region, the continent. As the Director General of the Nigeria Center for Disease Control and Prevention, I am humbled by the dedication and collaboration demonstrated by all of the NCDC team and stakeholders and partners here represented. Our joint efforts have brought us to this critical moment where we can analyze or indeed assess our nation's health security capabilities and forge a path forward towards enhanced resilience and preparedness. It is a pleasure to offer a warm welcome to the team of external evaluators led by Hendrik Jan, Owell, and Richard Garfield. I hope that apart from the hard work on the JEE, that you would have some time to enjoy what Abuja has to offer. Over the past years, Nigeria has faced progress and, of course, experienced challenges in public health. Our response to various disease outbreaks has showcased the fortitude of our healthcare professionals, the strength of our partnerships, and the indomitable spirit of our people. However, we also recognize that there is no room for complacency. The world around us continues to evolve, and with it, the landscape of health threats is becoming increasingly complex. Today's evaluation is a testament to our unwavering commitment to ensuring that our health security systems are agile, robust, and responsive. It is an opportunity for us to collectively examine our progress, identify gaps, and collaboratively design strategies that will steer us towards a safer and healthier future. I particularly welcome the comments of my sister, the country director of the US CDC, that all scores are important. And indeed, what is critical is what we do as a follow-up to the outcome of this assessment. I extend my gratitude to the World Health Organization, our international partners, and the diverse range of experts who have joined us in this endeavor. Your expertise and insights will undoubtedly guide us in our pursuit of excellence in this area of health security. Let us engage in these discussions with open minds, a shared sense of purpose, and a resolute commitment to the welfare of our fellow citizens. As we deliberate, let us remember that our work today, and indeed for the rest of the week, will have the power to shape the health security landscape of tomorrow. So, starting today and over the next few days, I encourage us to work with a determination to make Nigeria's health security stronger and more resilient than ever before. Thank you all and welcome.
Thank you very much, Director General, Nigeria Center for Disease Control. HARS has been a very agile, robust, and resilient and responsive system. We expecting other dignitaries, and I've been informed by the DG that as soon as we have the representative of the permanent secretary in the room, we may have to pause so that we can take the message. Apologies, we're trying to get some protocols fully recognized. It's been a long journey, I must admit, in the last 5 years for us as a country. And so far, so good. Okay. I've just been informed that we have been joined by the Permanent Secretary's representative. The representative of the Permanent Secretary, Federal Ministry of Health, is now in our midst, and we shall be bringing shortly his remarks for this great meeting. And, you know, if we have the opportunity and the privilege of having the political will and the leadership expected for us as a country, it's a lot of encouragement, and we are more confident than ever before that we are going to get it right and things will keep getting better. Our external evaluators, Director General, it's my pleasure to also inform us that in the last couple of years, we have been greatly supported by more than 40 partners across the world who have been working assiduously and tirelessly in support of this great task that we have before us. It's very challenging to recognize everyone by name now, but if you don't mind, may I crave our indulgence that we please put our hands together in recognition and appreciation of our tremendous support received from all our partners. A warm round of applause for every one of them, please. It's a very long list, more than 40 partners who have also been invited, and they are represented in this room. Thank you so very much for all you've been doing. We're very much grateful. The representative of the Permanent Secretary, sir, if you don't mind, may I kindly request for your opening remarks for this meeting. It's my pleasure to welcome the Director of Public Health Department of the Federal Ministry of Health in Nigeria. Ladies and gentlemen, please make welcome Dr. Chukwuma Ayaike. A round of applause for Dr. Chicks, please. Thank you very much, Director, sir. We're glad to have you here. Not so much.
Good morning, everyone. Good morning, Nigeria. I'm sorry for coming late. It's not in our character, but I was just told to come and represent the Honorable Permanent Secretary, Federal Ministry of Health, Nigeria, in the person of Ms. Kachalom Daju, who could not attend this very important meeting because she just came in last week, Friday, and then there's a conflict of occasion, so she had to ask me to come and represent her in this very important meeting. By way of protocol, let me just recognize the DG for inviting us to this very important meeting. Dr. Mary Boyle, the country director, US CDC, the MDS directors here, national observers, external evaluators, distinguished partners, gentlemen of the press, ladies and gentlemen, once again, good morning. As a messenger, I will just read out, her message for this very important meeting, and just for us to understand that we are very in support of what is going on here, and I think the catchword here is political will and being able to own whatever we can to give a very healthy Nigeria. So we welcome every support from all our funders. So I'll read her message, and this is her voice, just that is passing through me. It is my great pleasure and honor that I welcome you to the commencement of the Nigeria's second joint external evaluation. This momentous occasion marks a significant milestone in our nation's unwavering commitment to enhancing our health security and strengthening our preparedness response mechanisms. The joint external evaluation is a critical assessment tool established by the World Health Organization to evaluate countries' capacity across various areas of health security, with a focus on preventing, detecting, and responding to public health threats. As we gather here, it is crucial to reflect on the importance of this evaluation process in fortifying Nigeria's ability to safeguard the health and well-being of its citizens. The inaugural joint external evaluation for Nigeria, conducted in 2017, provided a comprehensive overview of our nation's strengths and identified areas for improvement in our health security systems. This collaborative effort involved multiple stakeholders from across government agencies, the private sector, civil society, and international organizations. The assessment's outcome provided us with valuable insights that have since guided our nation's strategic planning and resource allocation, resulting in enhanced coordination and a more robust health infrastructure in Nigeria. Today, we embark on the second iteration of this evaluation. We are presented with an opportunity to build upon the progress made since the last assessment. Nigeria's determination to enhance its capabilities in disease surveillance, emergency response, point of entry and borders, and laboratory system and workforce development is commendable. However, we recognize that the landscape of global health threats is evolving, demanding our continuous commitment to adopt and improve. The COVID-19 pandemic, a stark reminder of interconnectedness, has underscored the importance of a strong and resilient health security system. As we navigate the ongoing challenges posed by this pandemic, and as we prepare for potential future threats, the insights gathered from the joint external evaluation will serve as a roadmap to further alleviate the Nigerians' preparedness and response and recovery mechanisms. I encourage all participants to engage actively in this evaluation process, sharing your expertise, experiences, and perspectives. Your contributions are instrumental in shaping the recommendation that we made from the assessment. By working together, we can ensure that Nigeria's health security landscape is fortified and that our nation stands ready to protect the health and safety of all citizens. In conclusion, let us approach this evaluation with a sense of purpose, unity, and shared responsibility. Our collective efforts will undoubtedly contribute to a safer, healthier, and more resilient Nigeria. Thank you for your dedication, and I eagerly anticipate a meaningful outcome that will arise from our collaboration during the second joint external evaluation. I want to use the opportunity to thank everyone, the partners, the external evaluators, civil society, gentlemen of the press, for all the effort and support you've given to the government of Nigeria. And on this note, I humbly declare this meeting open on behalf of the Permanent Secretary, Federal Minister of Nigeria. Thank you.
A better round of applause for Dr. Chukwuma Yaheke for that great opening remarks. Thank you so very much, sir. And our warm regards to the Honorable Permanent Secretary, wishing her very the best in office. The Director of Public Health, sir, or representative of the Permanent Secretary, may I crave your indulgence to recognize in the room the representative of the Honorable, not really Honorable anyway, maybe he's Ambassador or what other titles they give that office. I try to get it right. But we have in the room the representative of the Office of the National Security Advisor, assuring us that it's not just physical health, even other external forms of health is well recognized. If I have your permission, I'd like to receive to the microphone for his remark on behalf of the Office of the National Security Advisor, Dr. Damisa. Dr. Damisa is in the house. A round of applause for Dr. Damisa, please. Speaking on behalf of the Office of the National Security Advisor for the country. You're welcome, Dr. Damisa.
The DG, Disease Control and Prevention, Dr. Fedayo. It's always a pleasure being part of this program. Standing on all existing protocol with all our partners, all appreciated. It gives us a great privilege to be part of this process. It's also interesting to be part of the first process in 2017 when JE was done. It became increasingly clear that national security and health security go hand in hand. And no nation is truly secure if the health of a citizen is threatened by seen or unseen forces. And with increasing changes of the battle space, from what is physically seen to microbiological space, it becomes increasingly clear to us that the NSA office cannot take a back seat in ensuring health for all. The effort of the armed forces, the effort of security intelligence agencies in providing epidemic intelligence of disease patterns across the world and in Nigeria is becoming increasingly clear. So I want to say on behalf of the NSA, Malamnu Rubado, that Nigeria is secure for us to work, and we shall keep increasing our stakeholders because a chain is as strong as the weakest link. The health link will not be that link in national security. So on this note, I welcome all of us to this JE, and we hope that our achievements, our recordings, our auditing, our archiving will speak for us in due time while we seek to build enduring health security. Thank you and God bless you.
Thank you very much, sir, for the remarks from the Office of the National Security Advisor. Well appreciated and recognized. The floor is set, distinguished ladies and gentlemen. Now to take us through the overview of Nigeria's health system, public health services, and health security. representative of the Permanent Secretary, distinguished evaluators, ladies and gentlemen, please make welcome to the microphone the Director General, Nigeria Center for Disease Control again, Dr. Ifedayo Hadetifa, for this overview. The DJ, please.
Thank you very much. I've been asked to give an overview of Nigeria's health system, including the public health services and health security. And I'm particularly pleased that, of course, there are many of those that are present here that were here for the first JEE. And I've actually played roles, whether in other MDAs or within the NCDC, and in contributing to the evolution of the system. So if I make any mistakes, please feel free to point that out. So, I mean, this is Nigeria. We know what our estimated population is. We are expected to be one of the most populated countries in the world by 2050. It's the largest economy in Africa. Often, while Nigeria is referred to or considered to be a country, we're actually a federating unit of 36 different countries. Most of the federating units have, more people in them than many of the other countries in the sub-region. We do have suboptimal health indices compared to some of the countries, our neighbors. We have the promise of a youthful population and the need to harness the demographic transition that we currently have. And we have political commitment for health sector reform, which, as you can see, includes pandemic preparedness and response as part of the 6 components. So, what do we aspire to? We aspire for political ownership of the health security process, but more importantly, in that subnational space that everyone has highlighted as the next frontier for investment. We certainly need more domestic investment in health in terms of budgetary allocation. We need to increase geographical access to health facilities, in addition to, of course, ensuring that we have quality health care at primary level and we achieve universal health coverage as well. Despite being Africa's largest economy and most populous country, as I've highlighted earlier, our age-specific mortality rate is really poor compared to our neighbors. And our neighbors, we're talking about the Republic of Benin, Burkina Faso, Cape Verde, Cote d'Ivoire, Gambia, Ghana, Guinea-Bissau, Guinea, Liberia, Mali, Mauritania, Niger, Senegal, Sierra Leone, and Togo. And certainly we want that to change. In terms of public health services, while we have seen some progress in terms of access from 1998 to 2019, there's still quite a considerable way to travel. As you can see, Nigeria really is only just doing better than the Republic of Niger in that figure. The availability and quality of healthcare facilities across Nigeria by state shows significant heterogeneity, both in terms of quality and even in terms of the number of people served. Let's talk about the health system. So the health system is implemented through a 3-tiered system of government, where the Federal Ministry of Health leads health policy development and implementation. Although the Federal Ministry of Health carries out this role, there's a need to sort of tweak our laws to ensure that the Federal Ministry of Health also has powers to assess compliance with the policy and standards that it develops and implements. We've got an estimated just under 35,000 health facilities in the country. Most of them, by far, are primary health care facilities, and really tiny number is tertiary. So clearly, the place to invest in is primary health care, and along with that, to ensure that we have universal health coverage as the foundation or building block for everything else that we do in health security. 26%, just about a quarter of all health facilities are privately owned, but they provide a disproportionately higher proportion of health care in the country compared to the public facilities. So in terms of communicable diseases, things that are likely to cause outbreaks or cause pandemics, the NCDC, as an agency of the Federal Ministry of Health, it has the mandate to protect the health of citizens through evidence-based prevention, integrated disease surveillance and response activities, whilst applying a One Health approach. And then we are expected to do this guided by research and led by a skilled workforce, which are all domains that are represented in many of the technical areas that will be the subject of conversations over the next few days. In terms of the animal side of things, the Federal Ministry of Agriculture and Rural Development leads on animal health in terms of legislation and policies. State governments lead in terms of disease control, clinical services, livestock quality control, meat inspection, and of course, agricultural extension services. Local government areas are responsible for mobilization and extension agents in operational actions along with state veterinary officers, livestock farmers, traditional institutions, and livestock and law enforcement agents. So what's the story of the NCDC? The idea of the NCDC was first proposed in 2007 or thereabouts by Professor Adenike Grange, the then Minister of Health, at the National Council for Health meeting, and the resolution or that prayer was adopted by the NCH. It took another 4 years for the project to start in the ministry through a memo signed by the permanent secretary then. And finally, 7 years later, the NCDC Act was signed into law. So there's a significant incubation period. But in the period 2 years later, from 2020 to date, the NCDC has prepared and led the COVID-19 pandemic response, along with responding to other concurrent infectious disease outbreaks. Some of what has been achieved since the establishment of NCDC as the National Public Health Institute are outlined here. We've got reference labs in 2 campuses in Lagos and in Abuja. We've got a stockpile. We are working on antimicrobial resistance surveillance, coordinating One Health. We have a fully digital surveillance system deployed across the country, and so on and so forth. So in terms of health security assessment and action plans, we've thankfully have significant participation by stakeholders from all relevant MDAs, and you heard from some of the representatives of those MDAs today. We certainly had them fully engaged in the self-evaluation phase of this exercise. And we continue to appreciate our representatives and indeed our partnership with the Federal Ministries of Agriculture and Rural Development for animal health, with the environment, with mines, steel and power, mines and steel, finance, budget and planning, as well as the National Office of the National Security Advisor. Based on the 2017 JEE findings, an intersectoral, or well, say multisectoral national action plan for health security was developed, and this, of course, was linked to I'm not sure I'm going to pay invoices at this rate. We can't keep swapping. It's not a renewal. Some of these other ongoing strategic plans, policies, and guidelines are listed below. National Health Sector Development Plan, for example, and the National Strategy on Immunization and Primary Health Care System Strengthening. So some of the health security assessment and action plans are highlighted. Of course, we heard from the representative of the WHO country representative about the 4 tools that are used, such as the SPA reports, the JEE, after-action reviews, and of course, simulation exercises. And we can see that Nigeria has been consistent with submitting its SPA report. We are now here because we are discussing or carrying out the second JEE, and we have conducted several after-action reviews for recurrent outbreaks. And of course, simulation exercises continue. And all of this feed into, of course, the National Action Plan for Health Security and our aspirations to strengthen health security in the country. It's a bit of a journey from 2017 JEE to what we expect to happen even next year and what we are doing now. So we continue to look forward to our collaboration and support of those represented here in continuing this journey towards strengthening our national health security. So, why are we here today? Certainly, what we want, this JEE 2023 or JEE 2.0 is an opportunity to assess the state of play since the first JEE in 2017, and to see what progress we have made given all of the concerted actions and investments in health security. The thematic areas are shown in preventing, detecting, responding, and of course IHR-related hazards and point of entry. And we know what we scored in the various areas in 2017, and we will hear on Friday what the new scores are for 2023. These were some of the priority actions that were identified under Prevent, and we can see the actions that we are taking so far, which will be the subject of discussions with the external evaluators and of course the internal all-country teams throughout the week. Under Detect, these were some of the priority actions: laboratory infrastructure, an integrated national laboratory network, sample and vaccine transport systems, and of course the human capacity part with the FETP training. Of course, our human capacity or public health workforce agenda goes beyond just training field epidemiologists, because there are multiple roles, expertise that are required in health security. Under Respond, these were some of the priority actions, areas that were identified, and these are the actions that have been taken so far. For IHR-related hazards and point of entry, we're actually quite delighted with the progress that was made for point of entry, and we hope that we'll continue to build on that. For chemicals, as you know, we are armed poison control. We know that this is an area that requires quite a bit of work, and we are keen to build on the progress that has been made so far. So some of the identified successes are highlighted here. We are very grateful for the high-level political commitment in terms of that provides an enabling environment for IHR implementation. Historically, since the first JEE, as you know, we have a new government. We've got transition even in the Federal Ministry of Health, as highlighted by the Permanent Secretary's representative. We have a brand new Permanent Secretary who arrived on Friday, and even brand new heads of departments who also arrived during the week. So it is indeed a testament of their commitment and recognition of the importance of this event that the Permanent Secretary has sent a representative, and he will do our utmost best, either by ourselves or send a representative to be here on Friday when the debriefing is done, so that we can receive this. It is possible that we may actually have an honorable minister in place before the end of the week, and I'm sure that if that happens, he or she will do their best to either be present or also send a representative. But please, our external evaluators and others, I think you should be reassured that the ministry is committed to the JEE. The ministry has worked very hard over the last 5 years, along with every other partner, to contribute to the journey so far, and that will not change. So some of the other areas of success include, of course, we've got PHEOCs at state levels, and we are working very hard to strengthen what's going on at subnational level. We are working hard to continue to make progress in terms of One Health coordination, and there's been significant change in terms of laboratory capacity. That's certainly one area where things are significantly different compared to, say, when Ebola struck. Well, we've tried to identify some best practices because, and we think certainly the health security story is about partnerships. We need to digitize surveillance to ensure that we can respond in real time. Along with digitizing surveillance and seeing data in real time is also our interest in timely detection, timely response, timely notification, and timely response. But we continue to work on our early warning systems by ensuring that in addition to case-based or indicator-based surveillance, we roll out event-based surveillance and hopefully now also roll out community-based surveillance. So, regardless of what the score is at the end of the day, we have a duty to collectively sustain all of the progress that has been recorded so far. We need to advocate, and we need help to advocate. If the Director General of the NCDC is asking the ministry for more money, and if the ministry is asking the Ministry of Budgets for more money, sometimes we assume that we are doing that because certainly we work in that space. Okay? So I'm arguing for more money because I'm the Director General and I need more money. But it is important that our efforts are complemented by partners, by civil society organizations, and by the populace in general to ensure that the government and those who truly control the purse strings recognize the importance of health and, of course, health security in general. More domestic funding is required so that there's less dependence on other external sources of funding and indeed credits. But current gaps in funding in the fiscal space, as the AFENET representative mentioned, do need to be addressed. You aspire to have more domestic funding. It's a journey. While you are doing that, you need to fill in gaps that need to be addressed right now at the moment, because diphtheria doesn't care whether you have money or not. The next Lassa fever season does not care how much is going to come in the 2024 budget. It will start in November, and you have to be ready to deal with that. We need improved coordination to achieve, certainly we need high-level leadership in all technical areas. We need synergy, so that we can have the greatest impact. And we certainly need to pay attention to what goes on in the subnational space. For implementation and monitoring, we will be working very closely with the ministers and permanent secretaries in all relevant MDAs to make sure that they find a way of keeping an eye on what their ministry and department and agencies are doing in terms of their contributions to national health security, and to be doing that on a regular basis rather than sort of in a more ad hoc manner when the next assessment or evaluation is imminent. So, as I close, I think, and I can say this with confidence, regardless of the score that comes, that there's definitely been progress. This progress now needs to be sustained across all sectors with investments and strategies, especially to increase state-level capacities. Collaboration is necessary, and this room is full of all partners, stakeholders, because there's already an interest in collaboration. So I'm preaching to the converted here. We just need better alignment and better synergy to achieve the greatest impact. Clearly, we cannot continue to do things as with the more of the same mantra. We need innovation. We need to apply technology. We need to apply new tools to what we do in the various technical areas in the health security space. And all of these will be important, or actually critical, if we are to accelerate the impact of health security interventions. We also need speed. As I've said, we need ambition and we need skill. Because, as I say, what you do in 4 or 5 states is not going to change the fortunes of 200 million plus people. You need to really have skill. We need dedicated funding for implementing health security capacities, and we are grateful that the government, as a commitment to that, has additional streams of funding coming both to the NCDC and to subnational elements, subnational levels through the Basic Healthcare Provision Fund. Certainly, if you ask me, I would ask that the percentage of the Basic Healthcare Provision Fund that goes to health security or to the NCDC gateway is increased, but that should not surprise you, really. Anyway, everybody, including my brother, Director of Public Health, will be asking for more money in the next budgetary round, and perhaps we will be told, well, this is all the money that is available. Go and do whatever you can do with it. So we need high positioning of the health security and health on the agenda of high-level government leaders. But again, this is already happening. The new government under President Bola Tinubu already has a health agenda. And of course, we know that the health sector reform report is very clear about actions that need to be taken, including actions that need to be taken in the area of pandemic preparedness and response. So, thank you very much.
Absolutely, there is a need to sustain the progress that we have made across sectors. Emphasis on the need to strengthen our strategies and interventions in this area. But much more importantly is the need for us to advocate for more resources so as to address the funding gaps identified. And with these, we know that we can only keep making more progress as we keep pushing onward and upward. Your Excellencies, distinguished ladies and gentlemen, a round of applause again for the Director General, Nigeria Center for Disease Control, Dr. Ifedayo Adetifa. Thank you, DG, for all you do. Much appreciated. It's been said that where a child grows should not determine whether he lives or survives. And that is a function of the health security of such location or that community. Moving on in this agenda, it's now my pleasure, the Honorable PAMSEX representative, ladies and gentlemen, distinguished partners in the room, it's my great pleasure and honor to take us through overview of joint external evaluation, mission, and objectives in Nigeria. To welcome to the microphone the lead facilitator, the senior advisor of the World Health Organization Global JHE Secretariat. Ladies and gentlemen, please make welcome Dr. Heng Jan Homen. A round of applause for Dr. Jayek, please. Thank you so very much, Dr. Heng, for all you do. You're much welcome.
Good morning, ladies and gentlemen. Your Excellencies, Your Excellency, the representative of the Permanent Secretary of the Ministry of Health, Excellency, the Director General of the Nigeria Center for Disease Control and Prevention, Your Excellency and other representatives of Nigerian ministries, departments and agencies, Country Director of CDC Nigeria, national observers, distinguished partners from WHO, FAO, World Bank, Africa CDC, ladies and gentlemen of the press, ladies and gentlemen, first of all, on behalf of the external team visiting you, I would like to thank you for Nigerian hospitality. Thank you so much. My name is Henk Orbel. I'm a senior advisor of the WHO JEE Global Secretariat, and I would pass with you in a short time through the JEE process. The context in which we are living, in which we all are living, is that not only the Africa region is a hotbed for public health emergencies and humanitarian crisis, it's the whole world. COVID-19 definitely not came from Africa. Avian influenza is affecting Africa, but is affecting the whole world. The world has become a global village. And what's happening somewhere today can happen here tomorrow. Therefore, it's important to prevent, to detect, and to respond. And to prevent, detect and respond, we need to ensure health security in Africa. In the end, you need to ensure health security in Africa. And to do this, we need to do a lot of things. And to see what is important and where to start, therefore, we have the JEE process. The JEE process started in 2015, and it is there to identify the most critical gaps for health security using a multisectoral approach, a One Health approach. Because what's happening in the animal world, what's happening in the environment, is also affecting humans. And more than 60% of the infectious diseases of humans originate from animals. Therefore, we need a voluntary country participation. We need coordination, and we need a multi-sectoral One Health approach. The history of JEE started in 2005. In 2005, the World Health Assembly adopted the International Health Regulations 2005. Nigeria was one of the countries voting in favor of this. And as part of the International Health Regulations, there was started a system to see if every country is doing what they are saying that they are doing. And they started with the SPAR, the self-evaluation, and in 2015 started the JEE. The tool was developed coming out of the Global Health Security Agenda tool. And this tool, Nigeria was among the first to have a JEE in 2017. In 2019, you had a midterm evaluation. And it would be normal that then after 2 years there would be a second JEE. But in 2021, the whole world suffered from COVID. So now you are here in 2023 with the second JEE, and I have to applaud Nigeria because you are the third country in the world having a second JEE. The purpose of a JEE tool is to gather data to evaluate capacities required for the implementation of the IHR. The IHR is key. And this tool was developed through international collaboration. The tool has 19 technical areas. I will come later to this. And the indicators in the tools combine qualitative and quantitative measures. There is a standard process in the tool, and this is standard all over the world. And it starts with a country that is volunteering for a JEE. It is Nigeria asking the WHO, can we have a JEE? It's not the other way around. It's not the WHO saying to Nigeria. It's Nigeria itself that asked WHO to have a JEE. Then the country conducts a multisectoral self-evaluation. You have done this. Then WHO is identifying a JEE team of international experts. And you can see them sitting there. I would like to ask the team to stand up, to show your face to the whole audience. They are coming from everywhere in Africa, from Gambia to Zimbabwe. They are coming from everywhere in the world, from the North America to Australia. So it's really an external group. Please sit down. Thank you. This JEE team is working together with you, with national experts, this week to try to find gaps and to try to identify priority actions. And there we need your help. We are here only 1 week. You know your country much better than we can know your country in 1 week. And we need to identify together what are the weak spots at the moment. Then we draft a report, we identify priority actions, and we will give scores. And I've heard the excellencies talking about scores. Here I would like to say the scores is not the most important of our work, it's the priority actions. We will deliver the report within 2 weeks after this mission, and then you will look at the report yourself, and if we reach consensus on the report, WHO will post the report only after your editing and after your clearance. Because JEE is a transparent process, because we are talking about transboundary health systems, One Health systems. And as good as you can read the report of Sierra Leone on the WHO website, Sierra Leone must be in the possibility to read the report of Nigeria. There are, and this is the most important of the slides I will show you, there are 12 basic premises to the JEE process. Oh, I have the wrong slide. This one. The JEE is voluntary. The JEE is One Health. It is about cooperation, not working in silos. And I have done many JEEs, and I have seen silos everywhere, and I'm sure there will be also some Nigerian silos. The JEE is not an audit. It is not an inspection. It is based on peers assessing peers. It is an external evaluation, and it goes through all the available information in order to develop, and here you can read it again, priority actions and scores. It is about the priority actions. The JEE process supports other assessments and integrates key findings also in our priority actions. It begins with the self-evaluation done by you. The key outcome of the JEE are these priority actions. And the JEE is based on openness and transparency. And this is also important, number 11. Because of the inherent characteristics of the JEE tool, any direct comparison between countries solely based on scores alone is invalid and contraindicated. And I would even go further. It will be very difficult to compare the scores of the 2017 JEE with the score we will reach at the end of this week. Why? First, the scores are mainly qualitative. Two, the teams are different from 2017. Here's another external team. You are also, not many of you were present in the 2017 JEE. Three, the tool itself is a living document. We are now working with 3.0, and in 2017 we had 1.0. So the tool is changing. Finally, the JEE, what we are doing here this week, is part of a wider global process to improve global health security. So it is not a standalone process, and we have to guide the process that what is happening this week will also happen in the same way in Tanzania, where there's happening a JEE this week as well. And it has to be the same when a JEE is held in Europe, in Asia, in Australia. We have 19 technical areas. Because of time, I will not name them all, because we are going through all these technical areas by this week. We have the scores. And the scores are between red and green: no capacity, limited capacity, developed capacity, demonstrated capacity, and sustainable capacity. Here I have to give a warning. The tool is working with benchmarks for every level. And when you reach some benchmarks for level 5, but you haven't reached benchmarks for level 3, then you can not get the score of 5. You can only get the score when the total benchmark is filled in, that is from the lower score. So we start looking from bottom up if you can get the right scores. And again, this is the system. It is done all over the world. In the end, this tool is meant to help to determine baseline capacity gaps and needs, to inform about the development of the plans and the roadmaps and what you've done, to measure progress, to highlight the gaps, and to inform, and this is important for your ministries, for your decision makers, to inform country-level planning and priority setting. And therefore, I would not fear having a low mark. I would even welcome a relevant and transparent and honest score that is helping you to put the finger on there where the gaps are, and to help you and help the decision makers in saying that's where the money has to go to develop it. In the end, we have the final report, and in the final report you will see the scores, you will see the strengths and the best practices, you will see the areas which need strengthening, and then you will see for each technical area 3 to 5 priority actions. After this, there will come a NAPS, a National Action Plan of the Health System. And this National Action Plan, with the help of WHO and another team, will use the outcome of this JEE tool to identify where are the gaps, where do we need to put the money first, where do we need to put our energy first, where do we need to put your energy first to save your people, to help your country, and also together, because as was said before, together we are much stronger and safer when we are doing this together. I'm looking forward with my team to a very fruitful and cooperative week. Thank you for your attention.
Can we put our hands together again for the team lead on behalf of the external evaluators? Thank you very much, sir. I believe the message is clear and well communicated. But I think as a country, having to know that only after Thailand and Syria alone, Nigeria becomes the third country in the whole wide world to have conducted their own second joint external evaluation. We deserve a better round of applause for this great feat. Good progress, and we know it can only get better moving on. So the objectives have been well communicated. Thank you very much, sir, for bringing this clear update. And we can assure you that we are ready and we are good to go to the plenary shortly after we are done with these opening ceremonies. So moving us forward, just a few announcements, then we will be ready to break. Permit me to inform us that as soon as we are done from here, we will be stepping outside to have our group photograph. The media team will be there to stand by. Thank you very much, our media colleagues, for the great job. Now you can keep pushing. So we'll be outside for the group photograph shortly. And after the group photograph, tea break will be the right thing to go for. So tea will be served in 2 locations, just for us to note. Based on the tickets you are being given, please check. There's one for event hall, and the other is for garden. So if you have event hall, you're going to be here. Then if you have the garden, you will be directed to where that will be just immediately outside. They will guide us to the right place to get that done. This will be for 30 minutes, and please, we are all here for the business of this evaluation. And so we like to kindly appeal to us to spend just 30 minutes for tea break. And we'll be back in the hall as soon as, I think, worst case scenario, by 12 o'clock. After the pictures and everything, we should be back in the hall by 12 o'clock to move the proceedings forward. Just a second. All right, so we just need to be here to go straight into the business. By 12 o'clock, we'll be all seated to move on to the real business of the day. The representative of the Honorable Permanent Secretary, sir, distinguished ladies and gentlemen, a very warm round of applause for ourselves for this great start to this meeting this morning. Thank you very much, and I can tell you, tea is served. Thank you very much. See us after tea. Yeah, we've said photograph is outside, so please let's move outside. All the front row seats, please, you will be served at the restaurant, please. All the front row seats. Kindly let's move to restaurant after and the evaluators, please. Please, all technical areas present, it's important that we maintain decorum on the tables so that we can hear the instruction once and for all. All right? So we'll be starting the presentations now. And as you can see the arrangement, we have the evaluators seated. And for each technical area, we'll have the lead presenter to take the podium. Then from that technical area, we'll have two other members of the team. Who are those discussing at the back? You won't allow us to continue this meeting. We will have two members of your technical area to sit with the presenter as soon as the presentation is done, so as you can take questions and provide response. Okay, so there will be three persons to join the, beg your pardon, three persons from your technical area to join the presenter on the high table to take questions and feedbacks from the evaluators. So we have two evaluators for each technical area. The evaluators will change. For each technical area, the evaluators will change. So for IHR coordination, we have this current set of evaluators. So when we move on to other technical areas, they keep changing them. All right. So for this section, which is IHR coordination, national IHR focal point functions, and advocacy, we have Dr. Lois Olajide as the lead presenter, and she's being joined by Dr. Oyeladun Okuromade, and also to join her is Dr. Shola Haruna. Dr. Shola Haruna, please. And Dr. Genom. Dr. Genom, resolved to save life. Dr. Shola Haruna, UKHSA, kindly join the high table. And from the evaluators side, we have the team lead for this section from the Gambia, Dr. Buba Manjang. And the co-lead for this section is Dr. Noor Halam from Australia. And of course, the team lead is still very much in the house, Dr. Henk from the Netherlands. A round of applause for this wonderful team as we commence these proceedings. Thank you so very much. So the stage is set. The additional point we need to understand is, please and please, I believe this has been communicated to us also, the time for presentation is going to be very strict as directed by the evaluators. Very strict. The time has been allotted based on the number of indicators we have. So we make sure that there's fairness, proportional distribution of time based on number of indicators. Are we together? So for those who have 1 to 2 indicators, you have 10 minutes to present. 1 to 2 indicators, you have 10 minutes to present. 3 to 4 indicators, you have 12 minutes to present. And above 4 indicators, you have 15 minutes to present. I take that again. 1 to 2 indicators, you have 10 minutes to finish your presentations. 3 to 4, you have 12 minutes to finish your presentation. And above 4 indicators, you have 15 minutes for your presentation. After the presentation, the floor will be open for conversation, for discussions, for questions, and other interactions. And the number of minutes assigned to that is noted by the evaluators and the other coordinators. We have a timekeeper for this section, and that's Dr. Kola Jinadu, who will be helping us to monitor time. So for each of your section, you will get a notice. So it's important that you look at his site. He's seated on that site. You will get a notice when it's 2 minutes to wrap up so that you can tidy up your conversation and discussion and presentation and move on. If you are not able to do that within your time, you will be disconnected from the microphones. apologies, we have to do that, right? So we move on now. I think that is clear to everyone. Are we good to go? All right. So to start, let's welcome for IHR coordination, Dr. Lois Olajide. Dr. Lois, the floor is yours, please.
Good afternoon, the DG and every other distinguished guest. And permit me to stand on the already established protocol. My name is Lois Olajide, and I will be presenting on IHR coordination, national IHR focal point functions, and advocacy. So this is the list of abbreviations to be used in the course of this presentation. Following the passage of the NCDC Act in 2018, Nigeria Center for Disease Control and Prevention was designated as the IHR National Focal Point. And as part of our responsibilities, the National Focal Point coordinates the implementation of IHR activities across the relevant ministries, departments, and agencies. Part of the coordination mechanism includes the IHR Technical Working Group, disease-specific technical working group like measles, COVID-19, and diphtheria technical working groups. The Nurses Committee, which serves as a platform for sharing surveillance information across the OH MDAs. There is also the OH governance structure in country. Advocacy, being a key element for IHR implementation, is actually factored into all the key activities, as mentioned earlier. And the IHR NFP also coordinates the development of the National Action Plan for Health Security and the Multi-Hazard Emergency Preparedness and Response Plan. The NAPS is a 5-year strategic plan which is developed to address the gaps from the JE, and it's also divided into a yearly operational plan for ease of implementation. For this technical area, there are actually 3 indicators as opposed to the JE 1.0 in 2017, where we had just 1 indicator and we had a score of 2 at that time. So the first indicator, which is the National IHR Focal Point Functions, we scored ourselves 3 based on the following. First is the first point is a clear legal and governmental mandate through the NCDC Act of 2018, which gives us the mandate to coordinate all the IHR functions. We also have documented IHR NFP terms of reference describing the roles and responsibility of the IHR NFP. We also have regular engagement with relevant MDAs and stakeholders using a whole of society approach. The availability of the availability of the IHR NFP to communicate with WHO at all times using various platforms. And however, due to inadequate consolidation of surveillance information from all the relevant sectors, from the disease-specific technical working group, other surveillance sharing platforms, we could not move to the next level, and that's why we have to remain on the level of 3. So our strengths and weaknesses, our strengths include the existence, as I mentioned, of the NCDC Act, which is presently being reviewed as we speak. Also we have existing structure for communication and collaboration with other relevant sectors. Like we have the SOP, Standard Operating Procedures, we have the IHR Technical Group where we coordinate and communicate with all the relevant MDAs. And there is also a process in place for timely report to the WHO through our dedicated IHR NFP email, the WhatsApp, as well as phone calls, which is usually available 24/7. The best practice actually is the inclusion of the Nigeria Governors Forum in all IHR-related activities, which is an indicator of good political commitment and is key for subnational health security assessment and development of the State Action Plan for Health Security. So the areas that require strengthening, so even though we have a structure in place for sharing information through the various platforms as mentioned earlier, like the disease-specific TWG and the NOSIS, which is a committee for all OH relevant MDAs, there is a need for consolidation of the surveillance information between the human, animal, and the environmental sectors. There is also a need for us to strengthen communication from relevant MDAs to WHO through the IHR NFP. Yes, there is that good communication from IHR NFP to WHO, but there is a need to also get the communication from the relevant MDAs to the IHR NFP and from the IHR NFP back to WHO. The challenge is the fact that, yes, we have electronic reporting platforms across some of these MDAs. There is actually a need for us to ensure that there is interoperability of these electronic platforms across all these relevant sectors. For the second indicator, which is a multisectoral coordination mechanisms, we scored ourselves 4, and also based on the following reasons. The first is the fact that there is a multisectoral coordination mechanism for IHR implementation in form of SOPs for coordination and communication. We also have the IHR technical working groups, disease-specific technical working groups. The IHR technical working group holds on a quarterly basis. There is also the dynamic risk assessment involving a multisectoral, multidisciplinary group, which is conducted to inform the activation of the EOC. However, many of these SOPs are due for review and update. There is also a mechanism for detection and responding to public health threats, available in the form of signal monitoring through our various EBS platforms. We have the daily public health intelligence meetings, and also we have SOPs for detection and responding to unusual events, including chemical and radiation emergencies. So there is updates on IHR implementation are also shared with relevant sectors, using the NAPS tracker, where every technical area leader and the representative actually monitor the activities, the implementation of those activities, and the update as regularly as possible. And we also have the IHR technical working group, where we share updates on the levels of implementation of these activities. The strengths for this particular indicator include the availability of SOPs as mentioned, the quarterly IHR technical working group where all relevant sectors are updated regularly. We also have the NAPS tracker as mentioned to track implementation of activities and to identify the gaps and challenges with respect to implementation. And also the constitution of the OHM governance structure, which has actually been inaugurated. The technical committee has actually been inaugurated to actually ensure seamless coordination and communication between all the relevant OH relevant MDAs. The best practices for this indicator actually is the subnational health security assessments, which have reinforced the multi-sectoral collaborations at the state level. There is also the use of the functional grouping approach, which was used in the last annual operational plan that was conducted this year, where all the technical area leads with the similar functions actually grouped together to ensure that there isn't any duplication of activities. And there is also the IHR relevant documentation archival system, which is presently on the AFITS platform of the NCDC, where all the relevant documents that will also be used for this, that have been used for this exercise have been uploaded. So we have all these documents uploaded on the IHR, the archival system that is presently on the NCDC platform. The areas that require strengthening is the need for us to actually strengthen multi-sectoral mechanisms at the subnational level. Yes, we have a structure in place, but there is a need to ensure that this is strengthened as much as possible. And also, yes, there are SOPs for communication and coordination, but there is a need for regular review and update of these SOPs to ease communication across the MDAs, and also the need for to strengthen the mechanisms for detection and response to public health events, also at the subnational level. Some of our challenges include insufficient funding to support this multisectoral coordination at all the levels, both the national and the subnational levels. And we also have a challenge of having inconsistencies in representation from MDAs at IHR functions, leading to the need to actually go back and update, the new individuals based on the activities that have been implemented. So for the last indicator, which is the strategic planning for IHR preparedness or health security, we actually scored ourselves 3, and the reasons for this are as follows. So there is the National Action Plan for Health Security, which was developed following the JE 2000 and the first JE that was conducted in 2017 to address the gaps and challenges that are identified from that exercise. And also we have a public health multi-hazard emergency preparedness and response plan. And all these plans were actually developed with the whole of society approach. There is also regular monitoring and updating of activities. We have been able to incorporate other IHR relevant hazards in the plan, like chemical events and other unusual events. And advocacy has been implemented in all our IHR-related activities. Following every IHR-related activity, including AOP, there is actually advocacy that's been factored in. But there is a need to have a structure in place, have dedicated guidelines and SOPs to speak to this advocacy. So the strengths include implementation of the NAPS and multi-hazard. Yes, the implementation of NAPS and multi-hazard response plan. We also have trained and ready to deploy rapid response teams in terms of outbreaks, and also the implementation of disease-specific contingency plan. We have one best practice, which is to incorporate lessons learned from CIMEXs and IARs into the National Action Plan, which was done in 2023 AOP. Okay. 1 minute? Yes. Okay. So just 1 minute, and I'll go straight to the priority actions based on the challenges that have been identified, which is first, you first evaluate to conduct an end-time evaluation of the NAPS 20 that's been from 2018 to 2022 to identify the gaps and challenges and the lessons learned from that, and also from the gaps that will be identified from this JE to lead to the development of a new action plan for health security. And for last but not the least is for us to, yes, we've started the assessment of health security in the state, but there is a need for us to actually complete this and also develop a state action plan for health security to address the gaps from the state security assessments. Thank you very much.
It's great.
The fact that you're coming is helping.
Okay, thank you very much for that wonderful presentation. Can you go back to the P3.1? The slide where you mentioned the rationales for scores, inadequate consolidation of surveillance information from all relevant sectors. And then the score given also is level 3. And as given in the level 3, there is a section on, is sufficiently organized, resourced, and available at all times to communicate with WHO. Yes, you can communicate and the like. So, can you tell us whether these areas are fully resourced? Because in one section, I've seen you mentioned lack of funding in some areas. Can you enlighten us?
Okay, thank you very much. So in NCDC as the IHR NFP, so we have a department that is actually dedicated to conducting and coordinating IHR-related activities, which is the Surveillance and Epidemiology Department. So in this department, we also have a division that also in these activities, all IHR-related activities. So we have enough individuals and personnel to actually ensure that there is a seamless conduct of all these IHR activities. So in terms of the human resources, in terms of the communication, actually, we have enough staff within that particular division who follow up and ensure that coordination of all any sharing information, surveillance-related information, and IHR-related information.
Do you have the terms of reference for the IHR NFU readily available? I mean, that you can show as reference material and is up and running.
Thank you. Let me add one or more points to that as the IHR NFP. For the level 3, while we're on level 3, in terms of the sufficient resources available for communication to WHO, she has rightly mentioned that we have that in country, and we normally communicate to WHO in case of any event within the required stipulated time. We have a dedicated email for the organization for that communication. We also use various social media communication to get across to WHO at when required. In terms of the terms of reference, yes, that is also available, and it's available for you to cite anytime you come to NCDC IHR NFP function. Thank you.
Okay, we will verify this. So, not to waste time, you said lack of interoperability between e-reporting. So is that ensuring proper communication between? Is that not a limitation?
Okay, so that is in country. Here is talking about communication to WHO, but inadequate consolidated surveillance information, which is what is actually the gap, where she also mentioned that we have the challenge of interoperability, but we have a manual way of sharing data across all the sectors. We have a data sharing, One Health Risk Communication data sharing platform, which meets once in every 2 weeks, where we share data. And we have a platform where we share any public health event occurring that needs immediate notification. But in terms of digitalizing the platform across all the platform, it's the gap that is remaining, but we share data manually across all the sectors.
Thank you. So going to P3.2, rationale for the score, multisectoral coordination and communication mechanisms, not updated and tested regularly. So how can that give you a score of 4 if these are not tested and we are not sure if they are really working well and what level they are? So can you justify this?
Okay, that's 3.2. Let's go to 3.2.
Yeah, P3.2, go to rationale for score. You will see multisectoral coordination communication mechanism, not updated and tested regularly.
Okay.
Yes. And you've given yourself score of 4. So can you justify?
All right, okay, thank you very much. So we have the SOPs that are being used regularly. And however, if you look at the criteria that need to be fulfilled to actually be on that level, we realize that so for us to actually be on that level, we realize that we've satisfied the criteria on that level 4. And if you read through that level 4 for, sorry, 1 minute. Okay, so it says
okay, not to cut you short.
Okay.
I'm not considering this being somehow a new area, variable or indicator. how do we jump to 4? It might serve as a baseline. But let me listen to your justification.
Okay, so in terms of the SOPs and being tested, yes, we do that occasionally. It may not be a regular event. We've had a full-scale CMEX on the yellow fever, which involved the multi-country, and we've had CMEX involving different, about 5 different countries where we tested our IHR, NFP functions and the SOP. I think that was conducted last about 2 years ago. So that is the justification for this and why we actually put it under review. But in terms of testing, in terms of testing the capacity of the SOP, yes, that has been done. Not even once, several times. Okay, so we invite Dr. Danjuma.
Just to add. Yeah, thank you, Dr. Ladon. So just to add, the criteria to be
you may sit and respond. We will hear you.
Okay. Yeah, so criteria to be at level 4, yes, is more sectoral coordination mechanisms, right, for IHR implementation are in place, disseminated, and are being implemented at national and intermediate levels, right? So I think she gave the rationale. Those are actually in place now in Nigeria. We have, based on IDSR, that has the FEM, which is the Public Health Emergency Committees. We have them in states, and then we also have state representatives here that can also testify to that they are actually in place. So I think why Nigeria is not in 5 is that these are not regularly tested as requested by 5, right? So I think for the 4, that's why they're in that level.
Okay. Yes, P3.2. You mentioned different persons from the same IHR implementing ministries and departments and agencies coming for coordination meeting, creating gaps or NAFs, institutional memory. So that is already an issue to be addressed. Are we sure we are okay enough to go for 4? Can you justify? Because that's a limitation.
Okay, so yes, I've seen a point at the national as well as the intermediate level. So in the presentation, we actually noted optimal coordination at the subnational, but not all the subnational. Nigeria is a large country. We have about 36 states plus FCT, and we have good multisectoral coordination. Actually, there's been One Health platform inauguration in some subnational states, not all. And there is actually no matrix to measure the proportion of states at the intermediate level that have multisectoral coordination. Why we remain on 4. It's available in some intermediates, but not all intermediates.
So just to also add, we also have some structures in place at the intermediate level that we average on for coordination. So one of such is the Public Health Emergency Management Committee, which is available both at the state and at the local government level. So these platforms are actually being used for coordination at these lower levels apart from the national.
Okay, thank you. So P3.3, we are almost there now. So looking at your rationale for score, yes, there is this issue of inadequate subnational capacity to develop, implement, and evaluate state-owned preparedness and response plan. So if you are giving yourself 3, what is the rationale?
So the rationale for being on level 3,
because at that level there is an issue. It's not completed. There is a limitation. So justify. What makes it holistic to give you 3. Why not 2?
So because we already have a national action plan.
You have national?
Yes, which is developed following the JEE. We also have subnational action plans. You know, we've conducted some health security assessment in some states, definitely not all the states. And in a few states, after the development, the conduct of the state action plan for health security, we've also gone on to develop the state action plan for health security. So that's actually on that basis we feel that we are on level 3.
Yes, but if the national, yeah, we can have everything fine with the national. But we know that at that level, in the regional or subnational, that's where most of the events are taking place. That's where the chunk of the activities are taking place. Root of the problem. So if that place is not organized enough.
No.
I'm coming. If there is a limitation at that level, the structure is not completed.
Thank you for noting that. So look at this indicator. This indicator is specifically addressing national and not subnational. Because if you look at the factors there, we have the National Action Plan for Health Security, which is being monitored and updated continuously. And also decision makers, as well as legislative bodies, are being carried along, are being sensitized, and we conduct advocacy to them in terms of matter related to IHR and health security on ad hoc basis. We do this even regularly. So this indicator is actually addressing the national level activities and not sub.
Yes,
and that is the rationale why we're on 3.
Yes,
Thank you.
Advocacy implementation in all IHR related activity not well structured.
It is.
It's not well structured. Can you look at that?
I understand what the query is, which is really what these workouts at subnational level. I think that's what the question is about. I think the justification for here and the importance of actually moving to subnational is a country-led decision that the country has made by itself, because they realize that that's going to be the next step. So that's well on its way in development. However, the justification for this particular score took into consideration the definition that is in this level. And then the evidence was mapped against what this definition is. Certainly, you're absolutely right in terms of the subnational coordination as well with national, and that's a work in progress. But we don't think that that necessarily precludes this score at level 3. Thank you.
Okay, thank you very much. Yes, so I propose this course to be looked at, but before I decide, I have to allow the external team, maybe they have something to add on to that. The external team, please, based on our discussions.
I agree with the national team. It appears to me that the key is that you are monitoring and implementing. That doesn't require you to monitor and implement everywhere. Nobody is capable of monitoring and implementing everywhere. But in fact, I would call you 3+. Maybe we have some differences on our team, but from my perception, could you put back the criteria?
So can I throw it?
We seem to have some
maybe because we have limited time, and on the scoring, it is the lead who takes the lead. So thank you for this. And now I give the floor to
Thank you. Thank you, Dr. Lois and the team. I know that you mentioned about the mechanism that has been in place and also the improvement that you have done over the years. And you have got a clear focal point, which is NCDC, and also the information exchange and mechanism, which is good. Great. But my main concern is what improvement have been done since the last, the first JEE. That needs to be substantiated with the evidence, not just only the SOPs or the guidelines or the NCDC's formation, but the mechanism and instrument that is being used not only from the human health, but also the other, the stakeholders that are involved in that collaboration. Because since yes, we have got the focus on all hazard approach and integrated surveillance of the multiple diseases. Everything together is the IHR, the coordination, and it's not just the one disease or disease specific. So the question is we have to have the evidence of the mechanism and the tools that have been used, not just from our side, from the human health side, but other stakeholders as well. So we have to have this evidence to substantiate that we have given the demonstrated capacity, which is a very high, score number 4. And as in the beginning, we mentioned our distinguished CDCs, the Honorable DG and other, that it's not just the score, but the score has to have a basis. If we put a 4, this will serve as a baseline. So where we will go the next, the JEE, for example. So my concern is we have to be very careful, and we have to have a clear evidence to substantiate that score. That is my, thank you.
Yes, thank you very much. Richard may give you that tree. We may not be looking at that much. That is his thought, but that doesn't mean that I am the lead. I have to listen to others. So that number 4 is my concern, not the 3 he's mentioning. Where you score yourself 4, I think we need to look at that properly. But if there is no other contribution coming from the external, we may allow the audience also to mention a few things before hands come in. Yeah, you can give them the mic if you want to talk, please, the audience. Okay, so there is no audience. So, Hans, you have something to say? What? Do you have anything? No. Okay, so I think we are done. Yeah. We need to propose the scores. Yes, for the scores, where we have the 4.
Okay, can I respond to that?
Yes, I'm coming. Okay. So, P3.1, your score there is a 3. So I'm suggesting we go to 2. And then P3.2, your score is 4. I think we are a little bit ambitious. We need to go to 4. We need to go to 3 instead of 4. And let me see the other one. P3.3, strategy plan. You have a 3 there, so we believe that 3 there. So that is all I have. But we will also do verification of some documents. We will be visiting sites to look at authenticity of those documents. You can draft, maybe it's not properly signed, maybe it's not validated. We are going to look into this. This is not an audit, but this is to make our systems work. If there is any gap, we may have further fundings and the like. So we are not auditing, but we are speaking our minds. Thank you.
And priority actions.
All right.
No?
Okay, to get our feedback.
So I'm asking, so whether you agree to what I...
No, I don't agree.
You don't agree? Okay.
No, so
you can justify.
if I would say this, for 3.1, our score is on 3. The reason being that if you look at the indicator level 2, it's talking about IHR NFP designated but has a duty officer system for urgent communication with WHO, but legal, normative, and institutional instruments and arrangement are insufficient. We have sufficient legal instruments, normative institutional instruments, as well as our SOPs and terms of reference describing roles and responsibilities. Here it's saying insufficient to communicate effectively. No, we have moved beyond this, especially with the NCDC Act. We have the legal mandate to communicate with WHO in any matter related to IHR. So for this, we are still proposing we're on 3.
Okay.
And the only part you are considering is the term of inadequate surveillance information sharing. That is actually adequate. To consolidate, that is actually adequate, but it is not digitalized. We have, it has not been, is not interoperable yet, but in terms of having a system of consolidating surveillance information across all mechanisms, it is in place. We have an Excel sheet that we use to update this information and will be made available to you during your visit. For P3.2, we have a fantastic multisectoral coordination mechanism. But for 4, you may say it's a bit ambitious because of the subnational level. We may agree to remain on 3, but for 3.1, we are on 3. I'll disagree on that. For 3.2, we have our IHR-TWG, which is a multisectoral coordination mechanism to coordinate implementation of IHR. We've inaugurated the One Health platform for multisectoral coordination, and we have a One Health governance structure in place. Aside that, we have also developed advocacy toolkit for NABs that we've deployed across all the MDAs for necessary advocacy. So I would still insist we're on 4, but if you want to drop us to 3 on that, fine. But P3.1, we're on 3. Absolutely on 3.
Okay.
Thank you.
Thank you very much. We will continue this discussion aside. We will sit and discuss because you have to convince me that I'm looking at the resource. So thank you very much. We will talk aside.
So, may I conclude that on P3, on the national IHR focal point coordination, you reach consensus on 2 indicators, point 3.2 and 3.3. You gave them both a 3, and you are not having consensus on the first indicator. Therefore, and also because you need to find priority actions together, I would kindly ask both teams to find a moment during this day to have a side meeting to discuss these final details. As soon as you reach consensus, as soon as you reach consensus on priority actions, you come back to the plenary and you tell what you reached consensus on. Thank you very much. Absolutely. And we see you back.
Thank you very much. A better round of applause for this team as they make their way back to their seats. All right. We have successfully broken the ice with the IHR coordination. And again, let's appreciate the evaluators team as they make their way back to their seat. Thank you very much. That's just a tip of how it's going to look like for the rest of the workshop. And so as we proceed, Dr. Hank will constantly be there because he is the overall team lead. Then is now being joined by the other external evaluators. I think so I don't murder your name. It's better I hand over the microphones. So you may want to just quickly introduce yourselves. Then we'll welcome the Nigerian team to the microphones. So if you don't mind, let's meet you. Your name and your country, please.
Thank you so much. As we wait for them, this is the team lead.
Okay, thank you for giving me the floor. I will start by presenting again myself. I don't know if you've done it. Okay, yes. My name is Guy Mulumoderwa. I'm from DRC, Congo, and working with WHO based in Dakar, Senegal. I'm here with...
Thank you so much. Good afternoon. My name is Tendai Makamure. I'm an infection prevention control specialist. I'm based in the Nairobi hub, working for WHO, supporting countries in East and Southern Africa. Thank you.
Thank you very much. Thank you so much. So, thank you, the international evaluators. And for the Nigeria antimicrobial resistance technical area, leading this team is Dr. Abiodun Egoenu. Let's make a warm welcome to the microphones. She will be supported this afternoon by 3 members of our team, and in no particular order. Start with pharmacist Vone Ihide from the NAFDAC, Nigeria. Also, Dr. Sunday Makama from the National Veterinary Research Institute, and Mrs. Haishat Shitu from Nesria. I'm sure 3 of them are in the room as they make their ways to the podium. Are we ready? Please, let's make it fast. All right, so the instructions remain the same. So we're expecting 3 people on the podium. I'm seeing 4. Hello? Sorry, I have 3 names. Pharmacist Vione Ikide, Dr. Sunday Makama, and Mrs. Aisha Shitu to join. So we have the floor now for Dr. Abiodun Egoenu, the technical area lead for antimicrobial resistance. External evaluators, I present to you the AMR team lead as takes us through our presentation. You have the floor. Your time starts now. Thank you very much. It's also you have 15 minutes. Thank you.
So good morning, everyone. I'm Abiodun Egoenu from the NCDC, and I'll be presenting for the AMR technical area. These are some of the abbreviations that we'll be going through. And I just wanted to start with saying that AMR is now the pandemic that's taken over the big 3, HIV and TB, and the World Health Assembly endorsed a global plan to tackle AMR. The NCDC, as the nation's AMR coordinating body, works with stakeholders to conduct situation analysis at a 5-year interval and develop the National Action Plan. And we also have a multisectoral governance structure, the AMRCC. We also have AMR Sentinel sites designated for and environment sectors, the NCDC NRL and the UCH Lab, and also the National Veterinary Research Institute, VOM, serves as the AMR National Reference Lab, and surveillance has commenced in the human health sector. We have access to EQA, and data is being collected primarily in the human health sector. MDR reporting and prevention remains limited, and data is reported to the World Organization for Animal Health for 8 years, and we have antimicrobial stewardship program, but limited to some tertiary facilities. So I'll go straight into our scoring. And we have the scores here. So 5 indicators. The first one talks about effective multisectoral coordination. And here we've scored ourselves 4, that we have a multisectoral national AMR action plan approved and reflects the global action plan objectives with a costed operational plan. So for coordination, on the right, you see the One Health governance structure, also the AMR as it feeds into this. This has been alluded to by the IHR coordination team. We have a multisectoral national AMR action plan, 2.0, and we're starting on 2.0. For the 2.0, situation analysis is 80% completed. We have a costed operational plan for 1.0 embedded in the National Action Plan for Health Security. There's also an AMR governance manual that has been signed by the 3 sectors. We also have, as part of this, subnational governance structure piloted in 2 states for scale, and the AMR manual exists. An AMR policy exists in the environment sector, and we have legislations that guide our work, including the NCDC Act, NAVDAC Act, Animal Disease Control Act, and the Animal Health Policy. Areas that need strengthening: domestic fund access is still an issue, and we also need to support the environment sector and ensure operationalization of the AMR governance manual at subnational level, including monitoring and evaluation of the National Action Plan. Our challenges were that in the NAP 1.0, the environment, food, and agriculture sectors were not well represented. I mentioned the manual is not yet operational at the subnational level. And then we need to look at funding. For AMR surveillance, we are at level 2. We collate data locally for common pathogens for hospitalized and community patients, but the collection may not use a standard approach and lacks coordination. And the rationale for this is, even though we have designated a network across all sectors, AMR data is collected primarily in the human health sector. We focus on bloodstream infection. On the left, see an image which is the national situation of AMR consumption and resistance for Nigeria 2016 to 2018. For the animal and environment sector, capacity exists, but we are yet to start surveillance. And for our best practices, we are starting an integrated national AMR surveillance system, piloting this in 1 state, and we hope to expand this to other states. We also have trained fellows across animal and human sector. There's also an integrated AMR information system, and we are currently looking at our national data and updating, and we will update our national standard treatment guidelines in human sector. Areas that need strengthening: AMR surveillance is yet to commence in the environment and animal health sector. The data produced on AMR in human health sector is not geographically representative, and access to EQA, we need to work on this. And limited access to diagnostics in human, animal, environment still remains an issue. One of the key challenges is health insurance coverage and limited domestic funding for laboratory infrastructure and capacity maintenance. Prevention of MDRO transmission in health facilities, we are at level 1. This is a new indicator, and looking at what we have, a national IPC manual exists that defines some MDRO and some containment strategies, and we also have a strategy for TB. And we have MDRO surveillance that is research-driven, conducted at the National Reference Laboratory at Ibadan in the human health sector. Areas that need strengthening: MDRO phenotype confirmation remains limited in human health sector and in animal health sector, and the genotype detection is also limited. Currently, we've not developed a strategy document for MDRO in human and veterinary hospitals. For 4.4, we are at level 3. The guidelines for appropriate use of antimicrobials are available, and antimicrobial stewardship programs are established in some hospitals. So currently, We have guidelines for appropriate use of antimicrobials available. These are some of the documents. A national antimicrobial stewardship program has been established, and the AWARE classification has been adopted in the national EML. Dissemination and monitoring of the use of these guidelines still remains suboptimal. One of the best practices is that the Honorable Minister signed the Muscat Manifesto. A national One Health community of practice for antimicrobial stewardship has been established and is being implemented. We have laboratories that conduct quality assurance for manufactured and imported drugs. So far, we also have 38 hospitals that have conducted point prevalence surveys on antimicrobial use. Areas that need strengthening: there's poor dissemination and monitoring of the use of treatment guidelines in animal and human sector, and then limited monitoring of the progress. We still have limited monitoring, and this includes monitoring rational use according to the AWARE classification, access to high-quality medicine, including tracking falsified medicines, and access to diagnostics before therapy still remains limited. Challenges include we need to engage more hospitals, and we also need to include the private sector. Currently, the private sector is not fully embedded within the AMS program. Then for indicator 4.5, optimizing antimicrobial use in human, animal health, and agriculture. National legislation exists to cover some aspects of national manufacture, import, authorization, safety, quality, and distribution of antimicrobial products and or pesticide. So as I mentioned, the minister signed the declaration to accelerate One Health actions on AMR for 2030 sustainable development goals, but we have poor enforcement of legislations. And NAFDAC is an agency that reviews some practices related to manufacture up to distribution of medicines, but the NAFDAC currently risk-based post-market surveillance that is not routine, and there's limited tracking of pesticide in food. So one of the best practices, our strengths include the documents mentioned before. Drug revolving funds exist in human and animal sector, and data has been submitted on animal consumption data, import data for the past 8 years. Our best practices, we have amended some of the laws in the animal health sector, and the Access Watch Reserve system has been developed and adopted for the essential medicine list. We also have a One Health antimicrobial stewardship strategy, which has been developed and validated. Areas that need strengthening: an antimicrobial use policy is yet to be developed in the human health sector, and we need to include AWARE categorization in the standard treatment guideline. Our challenges are mainly poor enforcement of laws that ensures antimicrobials are prescription only and bans their use as growth promoters in animals. The role of the environment is also not yet fully described in the AMS strategy, including disposal of unused or expired medicines. So this is our score. We tried to compare from 2017 to 2023, and we've moved more with effective multisectoral coordination, and we've made some progress in antimicrobial stewardship. So our priority areas for action for multisectoral coordination: we want to finalize the National Action Plan, map domestic funding institute and framework. We also want states to establish AMR governance structure within the One Health mechanism, and we are working closely with the One Health team to ensure that the One Health Steering Committee is inaugurated. For AMR surveillance, we plan to expand this network in humans and in animal sector, and commence surveillance in animal and the environment, and also the integrated AMR surveillance system and we want to leverage our One Health AMR information sharing system. Then for the MDRO, we would like to use some of the data we have to conduct a risk assessment and develop a response strategy for MDRO prevention and detection in hospitals. And for antimicrobial use, We are in discussions with other partners and agencies to bundle diagnostics with therapy for human health and increase private sector and community healthcare hubs' participation in AMR surveillance and antimicrobial stewardship programs. We also want to enforce legislation and policies that ensure rational use of antimicrobials, including post-market surveillance for falsified medicines. So these are some of the documents we've gathered under One Health, some of the laws that we've updated. In the human health sector, these are some of the documents we have. In animal health and the environment, we have also listed the documents. These are the team members that put together the presentation. Thank you for listening.
Okay, we thank you a lot for the presentation, which was very clear. And also, as we can see, Nigeria has done a lot on antimicrobial resistance. We really congratulate you. We will have some questions on your scoring. And unfortunately, we didn't meet before this meeting because we need really some documents to approve your scoring. Yeah, like if you can start by the first indicator, P41. I don't know if you can go back there, P41, for the multisectorial coordination on IMR. As I can see, you scored yourself at level 4. So level 4 means that you have already a multisectorial operational plan. So the multisectorial plan means that it includes people, animals, food, plants, and the environment. And also that multisectorial operational plan must be in line with the global action plan. In order really to increase the awareness of risk. So I don't know now, and also you've said that if you are at level 4 also, it means that the operational plan is already approved and also already being implemented. So if it's it's already being implemented, we need also to have some report of activities, I don't know, all those things. So I don't know if you can confirm with us if this operational plan is multisectorial.
So yes, it's multisectoral, and it is based on these pillars. So the pillars are based on the Global Action Plan, awareness, surveillance, stewardship, IPC, and research, which also includes economic case. So it's in line with the Global Action Plan. As I mentioned, we have the 1.0. So our National Action Plan expired in 2022, and now we are working across sectors to develop 2.0, the second action plan, where we have a report of what we've done, how many activities we've implemented, and also we have reports of our technical working group and AMR coordination committee meetings. So we have all those meetings where we report what we've done, and also when we come to the JEEs, we also track how much we've spent. Partners come together and talk about what they are going to give or what they are spending. We have those documents.
Okay. If you have all those evidence, I don't know, I give the floor to my colleagues.
Thank you so much for the presentation and the progress that you have shared on antimicrobial resistance. Again, to ask on the same question, I think when you raised the challenges, remember this indicator was on effective multi-sectoral coordination. And I think if you project on the challenges that you presented, there was ineffective coordination with animal health, and something that you mentioned, if that can be projected here. Yes, you say challenges, environment, food and agriculture, not well represented in the National Action Plan. So how can we say we have an effective multisectoral coordination when all these key sectors that are relevant to antimicrobial resistance and also the One Health approach, they are not well represented in the National Action Plan? Additionally, I also wanted to ask, on the technical working group that you showed on the organogram, we also do not see the environment, people, agriculture, and food. And do we have the terms of reference for this technical working group? Are they there? Are they documented? And additionally, even when we look at, can we go back to the indicator now? Sorry. Yes. The previous one, clear terms of reference and also regular meetings, so we see the participation of these key stakeholders, animal health, environmental health. Has that been achieved yet for us to say we have effective multisectoral coordination?
Okay, yes, sorry. So for the challenge, I think it was wrongly phrased. If you look at this, the organogram, or the yes. So actually, you see the logo of environment. So actually, the three sectors are well represented and they are co-chairs, both for the AMRCC and Technical Working Group. What I was doing was comparing the 1.0, the first action plan, to this second one. So in the 1.0, they were there, but there were some activities that were not captured. So I think that challenge was wrongly phrased. Then we also have the AMR Governance Manual. It's a document with the terms of reference for every level of the governance. So it's already there. And in that document, you see the list of stakeholders. And actually, agric and environment are there. So the CVON refers to the Chief Veterinary Officer of Nigeria, who is in charge of food and agriculture. I think that challenge was wrongly read, but well represented at the Technical Working Group.
So we have regular meetings already happening, and we have meetings of those reports that show us consistency and coordination between all the sectors.
Yes, we do.
Okay.
Okay, if so, I don't know if you have any other thoughts. I don't know if anybody has something to add on this.
Thank you for your presentation. I want to commend Nigeria for the efforts that they've made towards compliance on this technical area. My question is, I want to refer you to the JEE tool on P41, where you scored yourself a 4. And it says, the multisectoral national AMR action plan approved and reflects GAF objectives with a costed operational plan being implemented. And you just highlighted that 1.0 expired in 2022. What's happening now is a national effort to develop 2.0. So, on what basis would you score yourself a 4 if the document is not live? It's a document whose development is in process, if we are to stick by the tool that we're using for the assessment. Thank you.
Thank you very much. So we had this discussion at the last JEE, and for the 1.0, we are still looking at the activities that were not fully implemented, some of them because they were phrased in a way that we're not able to implement them, so we had to change the approach. So for those that we have not fully implemented, we are still working on those, and I do agree, but what we're basing it on is 1.0. For the 2.0, it's still in development. So we are still working. We still meet every quarter. And every quarter, we look at our activities, what we've achieved. The only thing is, what would we be monitoring and measuring it against? So what we do is projects, we look at what has been achieved, we collect those findings, and then we feed it into the 2.0. So, but for now, as you rightly said, what we are measuring against is 1.0, which is what we are still using till now, until the 2.0 is finalized. I don't know if I've answered the question.
I know you have tried, but you do realize that after this exercise, there will be a report that will demonstrate the level of capacity of Nigeria on this particular TA. So if it goes out that you're already on 4, and that means your action plan is approved, then why should the country struggle to even finish developing the tool that is required by the standard?
Somebody is raising. Okay. Thank you very much for the response again to the question. I think we recognize and identify the challenge that you raise. What we are looking at as a team and as a country also is, while the process is on for the 2.0, that the components or activities that are pending from the 1.0 is still being reviewed and revised and implemented. So in essence, if we don't have a plan completely, it's just that during the implementation of 1.0, we identified that there were gaps for which, of course, the review time has come to be able to develop the 2.0. So while that is going on, the 1.0 is still essentially in effect, even though technically by date it has expired. So I think that's where the challenge is. And if we look at the descriptive for the level 3, certainly we have gone past that. So I don't know if we are going to have a 3.5 like was suggested earlier, but I don't think that exists. But we recognize the point that you draw. Thank you.
Thank you very much, Dr. Biodun, for this presentation. I just want to respond to these questions raised. The team lead for the external evaluation mentioned the fact that we couldn't conduct JEE, the second JEE, at the right time because of the COVID challenge. However, it's not as if Nigeria's progress along the JEE line and implementation of national action plan has stalled. So it's the same scenario here. We have an action plan that has been implemented. It's been in the process of being reviewed. However, the implementation of that 1.0 has not stalled and it has not expired. It's still being implemented while we review and develop a second action plan based on the findings of the review. So I think that should be taken into consideration. Thank you.
Yeah, I think that's pretty clear for us to observe. Okay, we have another contribution there. That was the last for this. The closest mic, can we have the roaming mic to that end? Is it the one to come from here today? There should be a mic around that area too. No other one? Okay, then you have to run, please. Sorry.
Yeah, the last person, please, because we don't have time. We are having 5 interventions. Yeah.
We have less than 3 minutes for this section. Please, can you start with your voice, maybe? Okay.
Good morning.
Take the mic close to you so that we can.
All right, thank you. I'm pharmacist Silas Jacob Gulwa from Federal Ministry of Health, Food and Drug Services. To understand more on what Dr. Abiodun just said, and to add more flesh to the multisectoral approach that the NCDC is collaborating with other tripartite ministries, Ministry of Health, Agriculture, and Environment. The former Minister of Health had inaugurated the AMR committee that is domiciled within the ministry, comprising the hospital services, food and drug services, health and planning and research, and public health. This is because NCDC used to be part of the Ministry of Health, which has been designated as an agency. And all the AMR committee in the various tripartite ministries are domiciled within the ministry. So the minister deemed it necessary to inaugurate that ministry, and he domiciled it with the food and drug services. I think that is one of the plus for their multisectoral approach. Besides that, the aware categorization, which is a strong pillar of the AMR, and Dr. Abiodun has been part of the meeting that the review committee of the NDF EDL review committee, which is a statutory committee, that is the National Drug Formulary Drug, Essential Drug Medicine List Review Committee, had considered the embedding of the aware categorization into the National Essential Medicine List and the Nigerian Strategic Drug Treatment Guideline. Okay. So, in line with that, as part of the SWOT analysis presented, I want to say that the aware categorization, which is an essential pillar of the AMR, by the grace of God, it's getting validation before the end of this year, which is a big plus to what the SCDC is doing. And then I want to recognize the fact that the minister had now domiciled AMR committee as part of the tripartite ministries. Agri and environment.
I think your point is well made. Thank you very much for that contribution. So let's get back to the chair for your final submissions on this cause.
Okay.
And priority actions to go.
Okay, fine. Yeah, before I conclude, I don't know if you have a comment.
Okay, I think he has just buttressed some of the points that has been made. We work across all sectors. For the 1.0, we continue to use that while we revise and update the 2.0, develop and before implementing the 2.0 document. And we have all the documents that show that we have been meeting regularly, including budget lines. Thank you.
Okay. Thank you. So I don't know if it will be possible in a site meeting just to see those documents. And so we can keep this and with a question mark. Okay? Thank you. So let's go to the second intervention. P42 for surveillance of antimicrobial resistance. Okay.
But first I asked them to
No.
Yes.
Okay.
No. Because of time, we are doing it in a bit different way. We will propose, because we have 5 indicators, it's a lot. We will propose to you the scores by the external team, but we have to ask our whole team if they are in agreement with the scores proposed by the technical area lead. Then we ask you if you are in agreement, and then afterwards, if you are not in agreement, I ask you kindly to go together with the team lead in a side meeting. You will also need to go in a side meeting to identify the priority actions. So I give the floor back to the team lead to propose his scores, ask it to the external team, and then we confront the national team.
Okay, thank you. For this particular area, yeah, we do propose the level 3. That is so that means that here we have a national antimicrobial action plan developed, and also the coordination mechanism is functional with a clear terms of reference, and regular meetings are conducted. So this is our proposition.
And 2 and 3.
For the other indicators?
Yes, and also
No, and 2?
Yes, so
No, the second.
Now for the second indicator, yeah, we agree with you that we have at level 1. There we don't. The second for surveillance of yes, no, it's 1. It's 2.
4.2 is level 2.
Ah, no. Okay, fine.
Let's leave the screen on the objectives and indicators.
Okay. Fine.
Maybe to make it a bit more easier. The team lead is proposing for indicator 4.1 as 3, indicator 4.2 A2, indicator 4.3 A1, indicator 4.4 no A3, indicator 4.5 A2. So we have to ask the external team, are you in agreement with the proposal of the team lead of this technical area? If not, raise your hand. If yes, not. You are in agreement? Thank you. Then we have to ask you, are you in agreement with these score proposals?
Okay, thank you very much. We agree with all the scores except the one for governance, which we still think should be level 4. So we will still have to have a discussion. But the other scores marry what we have put there. So we agreed on the other scores, yes.
Okay, so you are saying for indicator, the first indicator, you really want a 4. Then I would like to propose to you and my team members to go in a side meeting somewhere today. There are 2 rooms for this. You discuss a bit more in depth why he thinks it's a 3, or they think it's a 3, why you think it should stay a 4. But more important than the scores is what kind of priority action can you agree upon. As soon as you have reached consensus, I would like to ask you to come back to the plenary, and then I give you the floor to tell the audience where you reach consensus on. For now, I would like to thank you. I would like to thank the external team very much, and I wish you a lot of success in reaching consensus. Thank you very much.
All right, thank you so very much. A warm round of applause again for this technical area. So the areas to agree on, there will be other side meeting. But I can tell us that we're making good progress. The previous technical area has gone into their parallel meeting, and they have also come up with a conclusion. So we are harmonizing and we're making good progress. And this is very encouraging, right?
So to the external evaluators, do you still need some time more, or we're good? Okay, so please let's appreciate the external evaluators too as they make their way back to their seat. Thank you so very much for this section. Well appreciated. So we move on to the next technical area, speaking to chemical events. And for this section, the external evaluators to be in charge are already making their ways to the podium. They will be introducing themselves shortly. But for the Nigerian side, the technical area lead for chemical events, let's welcome Mr. Abdul Fatai Olariwaju from the Federal Ministry of Health. He will be supported by other team members. For that group, we also have the following individuals to please join him. So we have George Okoye-Aguli, we have Ms. Quinta Kumefuna, that's from UKHSA, and we have Hamid Ibrahim. So the three of them to please make their ways to the podium to be joined by the lead presenter. But let's get back to the external evaluators for quick introduction. So we get to meet you. I think you are the one we are meeting fresh. Over to you, madam. You have the mic.
A very good afternoon to you all. Thank you, Nigeria, for your welcome. My name is Nyamazana Catherine, and I'm a public health officer. Thank you.
From which country?
Sorry?
From which country?
I come from Zimbabwe.
Oh, that's great. All right.
Not now.
Do we need to meet the team co-lead again? Okay, I think we already have the co-lead presented earlier. Okay, so the floor is yours, Mr. Fatai, sir. And you have 10 minutes for your presentation based on the number of your indicators. The floor is yours, and the time starts. Thank you very much.
So, I'll be moving it. Good day, everyone. All protocol duly observed. My name is Olarayi Fatai, Deputy Director and the Head of Chemical Management Program, Federal Ministry of Health, Abuja. I'm presenting for Chemical Event Technical Area. Next slide. So, background. We have a national chemical profile that gives the risk of chemical management in Nigeria. And we have important things of persistent organic pollutants. Persistent organic pollutants, which includes PCB, and also this one describes the impact of chemicals in the country, and which contributes to the morbidity and mortality in the country. And also, we have, in Nigeria, we have a chemical outbreak. We have recorded a major chemical outbreak in the country, which include soot in River State, which includes scissor in Niger State, and also which include sulfide exposure in Benue State. So we have two indicators for chemical event technical area, mechanism established for functioning, for detecting and responding for chemical event or emergency. We have availability of draft national guidelines. This is our strength. We have availability of surveillance system, which include event-based surveillance. We also have existing authorities for chemical management in the country, which include Nigeria Center for Disease Control, Federal Ministry of Environment, Federal Ministry of Health. We have Assistance National Committee on Chemical Surveillance and Emergency System. So we also have existing functioning laboratory for systematic analysis of chemical. which include, this laboratory includes National Agency for Food and Drug Administration Laboratory. We have Nigerian School of Pharmaceutical Research Development Laboratory. We have Nigeria, we have National Medical Research Laboratory in Lagos. We have investigation reports for chemical incidents that have already happened in the country. Mechanisms established for functioning and for detecting and responding to chemical event emergencies. Areas that need strengthening. We have effective chemical surveillance at national level and state level. We have alignment of chemical surveillance with existing surveillance system, robust monitoring and reporting of consumer product, functioning of the existing coordinated existing coordination mechanism. With the existing coordination mechanisms are a National Committee for Chemical Surveillance and Emergency System, and we have another important one, which is National Committee on Chemical Management. We also have laboratory support for chemical analysis. We have laboratory support for chemical analysis in this country. We have NABDAC lab, we have a NIMA lab, we also have other laboratories. And we also have laboratories we have other laboratories in the educational sector. For instance, the laboratory in different universities, we use them for analysis when we have a chemical outbreak in the country. Then, another important is capacity building and workforce development for chemical management. We have establishing policy information service in the country. So, concerning this policy information service, Nigeria, we have not gotten a policy information control and management center, but because of scarcity of fund, we intend to establish policy information service. And because of no availability of fund, the country intends to establish policy information service. And another important thing, Nigeria has drafted national guideline for the establishment of policy information control and management center in Nigeria. And this national guideline for policy information control and management center states 5 departments are supposed to be in policy information control and management center. These departments are clinical toxicology department, analytical toxicology department, toxicology department, monitoring and evaluation department, and emergency department. Well, because of scarcity of funds, we intend to establish policy information service in the country. And what Nigeria National Chemical System needs in the country is the policy information service. And we have already identified 2 healthcare facilities for us to establish policy information service, which is at University of Abuja Teaching Hospital and also National Hospital in Abuja. So our challenge is inadequate knowledge of existing chemical management related documents, no funding mechanism for implementation of activities, lack of interagency coordination, weak linkage between public health and medical health system. We also have staff affliction. We don't have enough staff in chemical management system. Enabling environment in place for management of chemical. We have national chemical provide, availability of chemical legislation. We have NESRA legislation, NABDAC legislation, EIA, Land Use Act, Nigeria Mineral Act. We have Factory Act, Fire Service Act, Functional National Coordinating Mechanism and Chemical Surveillance System, National Chemical Emergency Response Plan System. We have National Chemical Emergency Response Plan System. This one is domiciled in the Office of National Security Advisor in the country. We have simulation exercise has been conducted, etc. We have mapping of hazardous sites by NESRA. Simulation exercise have been successfully conducted by Office of National Security Advisor, Nigeria Center for Disease Control. The enabling environment in place for management of chemical events, we have an enabling environment in place, which include plans, policies, guidelines, SOPs, regulation, effective, timely implementation of the decision of National Committee of Chemical Surveillance and Management System, inclusion of IHR system in the National Committee on Chemical National Committee on Chemical Management, data generation system. Next, our challenge, we have number one, we have week coordination meeting of National Committee on Chemical Management, and the important thing is that the decision of National Committee on Chemical Management, National Committee on Chemical and Emergency System is not being forwarded to the NCCM. So the first indicator we scored ourselves to, the first indicator is mechanism established for functioning for detecting and responding for chemical events.
You have 2 minutes more, sir.
Okay, next one. Next one. The second indicator, we score ourselves to for the second indicator. The rationale for the score, for one, development of a draft national guideline on chemical surveillance, a system of chemicals event coordination mechanism system, availability of laboratory analytical capacity, availability of draft roadmap for establishment of policy information service. So for the second indicator, we scored ourselves to. The rationale for the score is that availability of regulation policies, we have different policies and guidelines for chemical events. We have natural policies, we have environmental impact assessment, we have land use act, we have mineral act, etc., etc. Availability of coordination mechanism for chemical event management, availability of national chemical profile, and chemical emergency response plan, conduct of simulation exercise, evaluation and development of improvement plan. So chemical event priority actions. Our priority actions are identify, describe priority chemical event, establish effective policy, institutional and regulatory framework, establish a policy information service, develop capacity for chemical event surveillance, develop capacity for diagnosis and treatment of chemical poisoning, improvement, detection and analytical capacity for chemical event, improve the harmonized existing public health surveillance system, which include chemical event surveillance and integrate with policy information service. So chemical event, so these are our references. These are the different stakeholders that participate in this in chemical events in chemical area. We have people from Federal Ministry of Health, Nigeria Center for Disease Control, Federal Ministry of Environment, Federal Ministry of Mines and State Development, National Agency for Food and Drug Administration Control, National Environment Center and Regulatory Enforcement Agency, Federal Ministry of Agri, United Kingdom Health Security Agencies.
All right.
Thank you. Another important thing I want to say that Nigeria is also signatory to international chemical agreements such as Rotterdam Convention, Stockholm Convention, etc., Minamata Convention, etc., etc. Thank you for listening.
Thank you very much. Chemical event, a round of applause for this team. So the floor is yours, the evaluators, please.
Thank you very much for that wonderful presentation. Indeed, there is evidence from your previous JEE that you haven't been sitting, you have been doing something. So it's very commendable. You were trying to close the gap. Thank you for that and well done. And then on the core capacity that we are talking about, it's chemical events. And chemical events, it's testing your capacity as Nigeria to respond to chemical event if it occurs. So this is very serious. When a chemical event occurs, are you ready to respond to that emergency? That is what we are testing. And we have to be sure because we are dealing with chemicals. And we know if we don't handle it well, you know what you end up with. Okay. So my question is, you were on, you scored level, you were scored 1 in your last JEE. And now you have scored 2. To me, that's 100% move from 1 to 2. You agree with me that that's 100%, is it? So my question to that is, can you confirm you've got guidelines, manuals for surveillance? For surveillance, I've checked on what you have given us. I'm convinced you have done quite a lot on surveillance. So my question is on, do you have guidelines and manuals that are speaking to assessment of chemical events, as well as the management of such events when they do occur, and also on intoxication and poisoning? do you have manuals and guidelines to those areas, or you still on the guidelines and manuals for surveillance? Can you confirm you have guidelines for all these areas?
Okay, we have draft national guidelines for chemical surveillance. Part of the component of draft national guidelines for chemical surveillance, we have intoxication that is included in it. You also know what I'm saying. So those are the major things that is being added. So I want my other colleagues to respond.
My name is Quinta Akomefula. I work with the UK SJC I'm the technical advisor on chemicals event. Now, concerning the guidelines, there is a draft. What we have now is a draft, and it's yet to be reviewed and endorsed, and there is still some work to go on because it doesn't quite reflect intoxication and some relevant issues that are supposed to be there, but the chemical events lead is working towards that. Very soon there's going to be a review of that document, and we are supporting to make sure that these relevant items are reflected on that. For now, no, they aren't.
Thank you for that response. All right, so with that information that you have just provided, can we agree that you are on 2? Are you still convinced that you are still on 2?
Concerning that indicator, I think we are on 2 strongly because we have all the necessary documents to support it, national guidelines on chemical surveillance and other policy documents and regulation documents.
But it's all that those documents are only speaking to surveillance mainly, right?
No, not only surveillance only. They also talk about poisoning. The National Guidelines on Chemical Surveillance also talk about poisoning. So some areas of it talk about poisoning. On draft National Guidelines on Chemical Surveillance, some part of the components talk about poisoning.
All right, then I'll have to hear what my other colleagues have to say about, or maybe I should give your colleague to explain further.
Okay, thank you very much. Okay, like my boss has already said, we have a draft national guidelines on chemical surveillance. It has different sections, but part of the limitation we have, and that is why the document has not been finalized yet. So there are some key areas, like what she mentioned, that will come in place, mostly the intoxication and poisoning section. It has not been finalized yet. Like we said, it's at a draft level. Between now and December, we have a robust document that reflects these sections. Thank you.
Thank you. My colleagues can also come in.
Yes, thank you very much for the wonderful presentation and then a lot of activities on the chemical events. For me, definitely, I agree with this course for 2 because level 1 is saying, that is CE1. You score yourself 2, and I agree, simply because level 1 is saying no mechanism in place. Looking at the presentation, I've seen series of activities and guidelines, the legal documentations and the like. But these need to be proven. We need to verify these documents to see whether actually what you're saying, what is prevailing. If that is prevailing, definitely 2 is okay with this. Going to the next one. Yes, so going to the next one, I'm also happy with some of the points that you mentioned, but the lead have to confirm this course. You either agree to maintain this course or to reduce it or to what. But I'm just speaking what I've seen as to definitely I'm in agreement with that.
All right, thank you. Do we still have any other comments from my co-evaluators? All right, okay. So maybe can you provide proof of these documents that are speaking to surveillance assessment? Can we have access to those documents so that I can also see that we have something?
You can have access to the document because most of the documents on chemical surveillance, anything on chemical surveillance is domiciled on national guideline, draft national guideline on chemical surveillance. They are all there. So those are that's one is very important. So when you open the national guideline for chemical surveillance, most of these things are there.
The documents are available and they are domiciled right now with the NCDC repository. So yes, you can have access to them.
Okay, thank you very much. Please, let's share. We also want to confirm with the documentation. So, okay, it's fine. We'll let it at 2. You have scored 2 on that capacity.
You have to propose to the external team. Your scores you are proposing first.
Okay. And I also need to confirm with the external team. Can we confirm the 2? The scoring 2? Are you all in agreement? Thank you very much. So it's a 2. And you can clap your hands. Thank you. All right, but then it's a 2, and then you need to continue working on this capacity and the indicator so that you polish up on the other things that, that it's also touching on. Thank you very much. We can go to indicator number 2 for this core capacity. So for this indicator it's requesting an enabling environment in place for management of chemical events. That is what it's requesting and where you are in terms of scoring. So you have scored yourself 2, right? Okay, so my question to this is there a plan to then strengthen assessment and management of chemicals, like in the areas of chemicals profile? Is it up to date? Are you implementing according to your manual on this indicator? What's happening? Like, how are you doing it?
Okay, we have a national chemical profile. We have a national chemical surveillance. We have a national chemical surveillance policy, which is domiciled in the Office of National Security Advisor. And this national chemical surveillance document shows the role and responsibility of every stakeholder when we have a chemical outbreak in the country. So we have all the relevant documents for this level. And it has already been submitted to NCDC.
Okay, and these documents are there for you to show us so that we can also see.
Yes, they are all available.
Okay, thank you. I don't know, I can give the floor to my co-evaluators if you've got comments to that indicator.
May I ask the external team, do you agree with the proposal? They agree.
Thank you very much. So yes, we'll maintain the 2, but like what we have done on the first indicator, you also need to continue working so that you close up and polish up on the aspects of policies, especially on documentation and I think on coordination aspects. So it's a 2 where it's okay, your score is 2, but continue working on it. Thank you.
Are you in agreement?
We agree.
So I may conclude that there is consensus on the scoring. The team lead already identified 2 priority actions to continue, but I think you will write it down in a more priority action way, and then we will share it with you. And then I can conclude that there is consensus on chemical events. So I thank you. I thank the internal team. I thank the external team. And this is the first technical area, and I would like to congratulate both teams where we reach consensus on stage, in time. That is very good. I hope we'll reach this more, but I also have a very happy announcement, because there was another team, another technical area that reached consensus in a side meeting. So I would like to ask the technical leads from the Nigerian team and the external team of the IHR focal point, P3, if they can explain what they reached. I ask the counterpart.
Okay, from the Nigerian team, the IHR lead. Okay, maybe Dr. Ladon will need to speak. Okay,
where is the anchor?
Just to explain the resolutions from the parallel meeting.
Okay, so for the IHR NFP function, which is P3.1, which is actually the major area of the gray area, we've agreed to remain on 3, pending the site visit, when we'll be able to provide documentation that will guide this call for us to remain on 3. So it's a conditional 3, and on Thursday, when they visit the NCDC, we'll provide the necessary documents that are necessary. Thank you.
Are there any comments?
Yes. So the priority actions for that is to make sure that all stakeholders are put in picture, in loop as to the limitations, the gap that we have. So, but as you mentioned, when we go to the field, the site visit, we'll verify these documents to make sure whether they are validated, they are of standard, they are usable. Then we'll give you that 3, no problem. So it's going to be 3, 3, 3. Okay, thank you.
All right, it's okay. Thank you very much. Thank you very much. Thank you very much. So that will determine what the final priority actions will be moving forward. Again, to the chemical event team, a round of applause for them as they make their ways back to their seats. Thank you so very much. It's been good progress since the last JEE. Thank you, the team lead from the evaluators side, the secretary Yamaza and a colleague, for the great job. All right. Distinguished ladies and gentlemen, it's my honor to inform us that we have been joined in this beautiful meeting by the WHR, in person of Dr. Walter Mulombo. He's here in our midst. A round of applause for the WHR. We're glad to have you join us this meeting. I wouldn't know whether the WHR has a remark or a comment or something you want to share with us. It will be our pleasure. A round of applause for him again as he makes his way to the microphones for his remarks. Over to you, sir.
Thank you. Good afternoon, all. It's a pleasure to meet you. Sorry, I was caught up in another assignment with the Minister of Health, so I couldn't be early enough to start the evaluation with you. But it's really a pleasure for me to see finally this day we've been looking for, to know how Nigeria has evolved since the last JEE. And also it's coming at a very opportune time with the reorientation of the fight against the COVID-19 and the termination of the acute phase, but still COVID-19 around. And with the pandemic having taught all of us lessons on how we could better prepare. We hope it has taught Nigeria on how to adjust some of the issues and challenges that are on our way on IHR. And you all know that the IHR itself is being revised. and some of the articles are being debated. Later next month in New York, there will be a discussion on pandemic preparedness and response and pandemic treaty. So I believe Nigeria is lucky to have this JE at this particular time, because it will enable the Nigerian authority to really input meaningfully in the discourse on the revisiting the IHR provision, but also in informing the hopefully soon to be endorsed pandemic treaty. So I'd like to call upon all of you to be frank and to reflect on our strength, on our area for improvement, but also taking advantage of our expert, external evaluator, to really give us an opportunity to have a second look into our policy, provisions, and our readiness to respond to the next pandemic. The pandemic we've been waiting for hasn't hit yet. We are preparing for an influenza pandemic. We don't know when it will hit. We had COVID-19 pandemic, we saw how we struggled. So really a good opportunity, and thank you all for your time and your dedication, and I look forward to working with you and the rest of my team to support this exercise. Thank you.
Thank you very much, WR. We most sincerely appreciate the great support over the years for what WHO has been to us. It just occurred to me when the last team was presenting, when Dr. Catherine was leading, and she said she's from Zimbabwe. I remember I was part of the external evaluator to Zimbabwe JEE some years back, and so it's good. It brings some reminiscences and some nostalgic feeling. Great to have you here in the room. And thanks to WHO for the support. Thank you, everyone. So we need to move on. I know it's almost time for lunch, but please bear with us. We're making a bit adjustment on that agenda, and we will just take one more presentation, and then we'll be doing for lunch. So the next technical area to present will be zoonotic disease. Zoonotic technical area will be the next in this order. And for this technical area, Director General, Your Excellencies, distinguished ladies and gentlemen, let's make welcome the team lead for this technical area in person of Dr. Nasir Ahmed from the Nigeria Center for Disease Control. Dr. Nasir, please. He will be joined by Dr. Zira Abraham from the Federal, am I correct? FAO. Dr. Zira Abraham is from Food Agriculture Organization. Also joining him will be Dr. Jerry Pantuvo. Dr. Jerry, is Dr. Jerry still in the room? Okay, you're welcome, sir. And last but not the least will be Dr. Salome Bawa. Dr. Salome Bawa from the Federal Ministry of Agriculture, and Dr. Jerry from the UK HSA. All right, so that's the team from this side. From the external evaluators, let's make welcome Professor Richard Garfield. A round of applause for Professor Richard. And he will be leading this engagement, ably supported by the other colleague whom I will be getting his name now. It's a quick introduction. I think it's good to hear from you directly also.
Thank you. My name is Geoffrey Jagero, Senior Technical Advisor, Minister of Health, Nairobi, Kenya.
And you know me, I'm from the US CDC.
Okay, zoonotic disease technical area. They will be spending how many minutes? So they have 10 minutes for the presentation, and the discussions will follow. Dr. Nasser, the floor is yours. The time starts now.
The Director General, Nigeria Center for Disease Control and Prevention, distinguished external evaluators, permit me to stand with the established protocol. So I'll be presenting
for zoonotic disease technical area. And my name is Nasir Ahmed. So these are the abbreviations of what is contained in this presentation. So, and a little background on zoonotic. Okay, the background or overview of stakeholders and their responsibilities. Something actually is missing. Actually, it's about the background on zoonotic diseases. I don't know, it's kind of missing. Okay. So zoonotic diseases are diseases that are transmitted between humans and animals naturally within their shared environment. Zoonotic diseases they form about 60% of all human infections are of animal origin, and about 75% of emerging and emerging diseases are zoonotic in nature. The country itself has demonstrated capacity for coordinated surveillance in both animals and public health sectors in different outbreaks. We have an example of the COVID-19 outbreaks, and most recently we have the anthrax outbreak. Before now, the country has about 10 prioritized zoonotic diseases, but due to changing dynamics, the country reprioritized these zoonotic diseases to 6. And we have them here: rabies, H. pylori, Lassa fever, monkeypox, bovine tuberculosis, and yellow fever. There has been significant improvement in deployment of One Health approach for recent response of zoonotic disease outbreaks. The technical area has seen so much improvement in recent times in both its scores for both indicators. Before now, in the midterm JE, we had 2 indicators, but now we have 3 indicators. We have a very new indicator in this technical area. And of course, there are limitations to these technical areas, and this is our lack of implementation of these strategies at the subnational level. So this is an overview of stakeholders and their responsibilities. So in the surveillance of zoonotic disease, that is P5, the first indicator, we've scored ourselves 3. And this is largely because we have a multisectoral technical working group for all the prioritized zoonotic diseases. And we have evidence of coordinated surveillance for anthrax, H5N1, Lassa fever, among other diseases. We've also conducted numerous joint risk assessments for diseases like anthrax, H5N1, Crimean Congo, hemorrhagic fever, and so on. This zoonotic technical area have also established a national One Health risk surveillance information sharing group for easy dissemination of information across all relevant sectors. We do conduct regular meetings on a monthly basis, and that justifies why we are on 3. So some of our strengths are presence of published and agreed list of priority zoonotic diseases and reprioritized list using the US CDC reprioritization tool. We also have availability of National One Health Risk Surveillance and Information Sharing Group, availability and implementation of the National One Health Strategic Plan, which has been signed and endorsed by the 3 line ministries. We have established surveillance systems in humans, animal health, and also environmental health, including wildlife. For best practices, we have a prioritization list from TAP 10 to 6 for maximum collaboration and funding across all sectors in 2022. We do horizon scanning of One Health threats through EBS, event-based surveillance, and also risk surveillance and information sharing group. So areas that need strengthening are laboratory surveillance, interoperable platform, though we have our information sharing mechanism, as I mentioned earlier, the NOSIS. We also need strengthening in capacity for surveillance and management of zoonotic diseases, analysis, dissemination, and usage of surveillance data. Some of our challenges include inadequate and often delayed budget, that is for One Health activities. We have attrition of trained workforce, and then as the DJ mentioned earlier in his presentation, that we have a federation system that's almost difficult for you to enforce national policies at the subnational level. Insecurity across the subnational makes it quite difficult for us to implement most of our policies at the subnational, and then we also have hard-to-reach terrains. So for 5.2, response to zoonotic diseases, we also rated ourselves 3. And this is a multisectoral operational mechanism for coordinated response to outbreaks of endemic, emerging or reimagined zoonotic diseases by humans, animal health, and environmental health sectors. As I mentioned earlier, we do have a TWG which transcends to an emergency operation center during an outbreak. We have public health emergency operation center across the country, which is multisectoral in nature. So some of the strengths are joint training for One Health workforce. We have the field epidemiology training program. We also have presence of joint rapid response team during outbreaks, simulation exercises for diseases like Ebola and also for yellow fever. We have national One Health strategic plans. We have plans for rabies elimination, Lassa fever strategy, and other strategy for the prioritized zoonotic diseases. We have reports on the National Multisectoral Coordination Mechanism operationalization training, and also I've mentioned earlier of the joint risk assessments that we've done across several diseases. For best practices, we have the presence of multisectoral, multidisciplinary public health emergency operation centers or technical working groups for the prioritized zoonotic diseases, deployment of joint rapid response teams during outbreaks. And we've seen that during COVID-19 outbreak and most recently during anthrax outbreak. We have contingency plans for almost all the priority zoonotic diseases, rabies, anthrax, Lassa fever, highly pathogenic avian influenza, etc. One Health zoonotic disease prioritization and risk communication workshops at the national and currently at the subnational levels. We have also National Veterinary Research Institute supporting diagnosis of COVID-19 during the heat of the pandemic, and they're also helping us with diagnosis of anthrax and also rabies in humans. So areas that require strengthening will be stepping down the operational plan to respond to all priority diseases at the intermediate and local levels for all relevant sectors. However, I'd like to mention that we do have this highly functional at the national, but then we need to go down to the subnational. Routine reports, information exchange, activation of response mechanism between the sectors, response timelines, and of course, routine monitoring and evaluation of the multisectoral coordination mechanism for response. For some of our challenges include inadequate and often delayed budgets, attrition of staff, we have somewhat poor documentation, and of course, insecurity across the country. For sanitary animal production practices, this is a new indicator for this 3.0 tool. So we've actually scored ourselves 2. And this says some activities are in place to develop and promote good sanitary practices in animal breeding and production of animal products, limiting risks of transmission of zoonotic diseases. Our strengths include implementation of some activities to develop and promote good sanitary practices in animals, in animal breeding and production of animal products, presence of standard operating protocols for abattoir operations, meat inspection, artificial insemination, dairy hygiene policy, hatcheries, and food production policies. And of course, there's also a presence of functional food safety committee. So for best practices, we have AMR community of practice to reduce use, abuse, and misuse of antibiotics in food animals as growth promoters. And we have an existing CODES committee and also existing national aquaculture strategy. So areas that require strengthening include adapt breeding practices to align with international standards, animal identification for animal disease control and traceability, animal welfare, enforcement of biosecurity, ensuring food security from farm to fork, enforcement of methodologies to improve farm practices in Nigeria. The challenges include inadequate veterinary workforce in service at the federal, state, and local government levels to meet demand in meat inspection, production, and regulation of farm animal practices, inadequate funding, and insecurity, especially at the subnational level. So these are some of our priority areas for action. The first one is laboratory surveillance for priority zoonotic disease pathogens, and including wildlife across all relevant sectors at all levels of government. Interoperable platforms or information sharing mechanism between relevant sectors at all levels. We currently have it at the national level. However, we need to bring it down to the subnational level. Capacity on surveillance and management of zoonotic disease at subnational level. Analyze, disseminate, and use surveillance data for disease prevention and control across all relevant levels. For response to zoonotic diseases, the priority areas for action include disseminate and expand the operational plan to respond to all priority zoonotic diseases to intermediate and local levels for all relevant sectors. Regular analysis, reports, information exchange, and activation of response mechanism between sectors at national and subnational levels. Develop strategies for improved response timelines, and of course, routinely monitor and evaluate the multisectoral coordination mechanism for response. For the sanitary and animal production practices, we need to adapt breeding practices to align with international standards, update and implement policies for animal welfare, enforcing biosecurity measures on all farms, markets, and abattoirs, ensuring farms' food security from farm to fork, and enforcing methodologies to improve farming practices in Nigeria. So these are references and also supporting documents.
Right.
For all the indicators.
Okay.
And these are the multisectoral team members.
Absolutely.
Thank you for listening.
Thank you so very much. A round of applause for the zoonotic technical area. Thank you so much, Dr. Nasser, for walking us through this. Professor Richard, the floor is yours for your feedback.
Thanks very much. In the first JEE 2017, the scores were just at the very bottom. The system was just beginning, and there wasn't even yet a prioritized list of zoonotic diseases. So you can see that there is progress in this area. There's no question, now you have a list of prioritized diseases, and in fact, you're talking about updating it. This is like 2 steps ahead. I want to ask you about the first criteria. You've described, and this is my biggest question among the various points, you've described that you have coordination in surveillance. That's part of the criteria for the score number 3, that a prioritized list of diseases has coordinated surveillance. Yet many of your challenges or weaknesses and things that need to be done have to do with the development of coordination. So it's not yet clear to me how much coordination actually exists. Can you describe some more about this? And this will be an important topic for us in our field visits, and to look at your documentation, to know if we can really say that coordination of surveillance activities is in effect already.
So thank you so much for this question. I'd like to clearly mention that at the national level, we do have strong coordination mechanism across all the sectors. We have multisectoral technical working groups, which comprises of members from all relevant sectors and also partners. We do have conducted joint risk assessment, which includes colleagues from all the sectors, agri environment, and also partners. These are actually done at the national level. Where we are still lagging is at the subnational level. But at the national level, we work collaboratively together.
Essentially, the national level is where we sit down and make a plan. And implementation is always at the subnational level because zoonotic diseases are not happening in this room. They're happening out where people live and all. That's the challenge for all of us.
Yeah, okay. Dr. Jerry wants to add to this.
Yeah, so it goes beyond the plans at national level. Where the challenge is that most of the time the national level has to go to the subnational level to implement some of the activities. And what we will want is the subnational level taking ownership and implementing the activities at that level and then requesting for support. So that's where the challenge is. But there's certainly implementation, but it's mostly driven by the national level.
And being that coordination is quite subjective, for you to know the level of coordination, at the national, just as they both said, we have a team. It's beyond just policy making. This is a team that actually goes down to the field to support response. So it's beyond just policy and paperwork. It's actually real work on the field too for the national team. Thank you.
And actually, to add to that, we also have capacities at the subnational level. We've not cut across all the states, but we have some state trained on so many of these things. So they are also supporting whatever we have, but we've not covered all the states of the Federation.
For the next variable, 532, you've described the correlation of your response. And you gave actually some examples of where, in response to an outbreak, there was some coordination of activity. And I know for Lassa fever, there's been a big problem and a big focus on improving that. So I can see more of your activity in terms of the coordination of response than I'm yet seeing about coordination of surveillance. And we'll ask to look at some of your documentation and talk about this to understand it better. Coordination of surveillance is often elusive. Here, we've heard about that in some of the other areas already, and in many countries. Surveillance systems may be independent and uncoordinated. The development of that coordination of information is actually what you described as one of your major challenges for analysis. So we want to look more into this and to think about the steps and opportunities to improve coordination of surveillance. Moving to the third criteria, which is the new one. I found your presentation of the AMR community of practice to be important and original. That's where coordination really will make a difference between animal and human sector. Could you describe a little more what that community of practice looks like?
Okay, I'll give that to Dr. Saloni. Community of practice, AMR.
Are we? No, we're not talking about it. Yes.
Do you want the question repeated?
Yes.
So she will want the question repeated, maybe the last question.
Because
wasn't clear.
To describe for us what this community of practice for AMR with zoonotic illness, what is it? Who's involved and what do they do?
AMR. Yeah.
Antimicrobial resistance and zoonotic disease community of practice. Is Dr. Gwene still in the house?
So when we speak about the One Health approach, you know that the environmental sector, the human health sector, and the animal health sector are all involved. Now, the AMR community of practice actually has people from all these sectors. So whatever it is we are achieving in AMR comes, it's One Health AMR. So the three sectors, majorly, including some other sectors, come together to form the community of practice. So yes, as you said, the AMR comes as the right medium kind of to improve coordination, and we know about that, and you could see even from the scores for the AMR that there is great improvement in that. So yes, that coordination in AMR also has an effect on what we are doing with the zoonotic diseases. Thank you.
Thank you.
Thank you. Okay, so there's a comment here.
Yes, thank you. Thank you for giving me the floor. I want to back up the team, especially on AMR, and the best practices that exist in the country in terms of surveillance. Currently, actually, I want to give one example. Currently, you have a mission involving the multisectoral stakeholders, the FMAD, the Ministry of Environment, NCDC, going around the country and assessing a number of involved laboratories who are doing the surveillance of AMR. I should give an examples to show that human and vet laboratories are involved, and also teaching hospitals who have these laboratories to survey the AMR. We have reference laboratory in Abuja, Lagos Teaching Hospital in Lagos, the College Hospital in Ibadan, National Veterinary Research Reform, University of Ibadan Veterinary Teaching Hospital, National Fisheries Laboratory in Lagos, National Environmental Standard Integration Agency Laboratory in Port Harcourt, to say that there is really a mid-sectoral surveillance of AMR in the country, also including different stakeholders covering One Health. Thank you.
Okay, Prof. What are your thoughts further on this? Would that be fine for now?
Let us go on to comments from our co-lead.
All right.
Thank you so much for your presentation. I just have a few comments to highlight. Number one, I think it's impressive the efforts that the country has made on this technical area. But I just want to highlight one or two things. The first comment builds on Rachel's comment about the need for all sector surveillance at all levels. It's not clear, on one side of the presentation, the surveillance is very well structured, it's happening. But on the areas that require or that need strengthening, it also pops us as a need. So you need to be clear which is which. Is it a weak area or is it a strength for the country? Secondly, I think there's a joint risk assessment at national and subnational levels. I think that's very commendable because by and large, in most cases, we just come across people talking about risk assessments at national level, and they think that is sufficient. So kudos to you. I picked something about AMR COP to reduce the use of drugs in animals as growth promoters. And I highlight this because during the presentation by the AMR team, they said that this is a weak area. And here you are presenting it as one of the strengths. So I think it's a question of the left hand not knowing what the right hand is doing. And from what the explanation is just provided, he's mentioned that this is an all sector-wide activity bringing human health, animal health, and teams from the environment sector. And yet, the team that presented the AMR were very clear that this is one of the weakest points. So I think because this is the Nigerian government presentation, there's need to speak with one voice. Otherwise, thank you so much.
And let me ask Hank, who is a specialist in this area, also to give some observation.
Well, thank you. I'm a veterinarian by profession, and I work long for FAO, so I have some background information, and I have a question on priorities and on things that you are identifying yourself that need strengthening. One of those is animal identification. That is at the basis of surveillance, of everything related to animal health. So I would like to ask you a question when you are saying strengthening animal identification. What does this mean? Is there no identification of bovine or of goats or of poultry? Can you explain a little bit how the animal, what is the level of animal identification in Nigeria?
Okay, I'll take the last question concerning animal identification. For Nigeria, as we speak right now, we don't have an animal identification, and that is why we identified it as a weakness, and we need to strengthen it. The reason why we say strengthen is because there are some private individuals that have been able to carry out some identification of their animals in their farms, but as a government, the government has not, doesn't have a system in place for animal identification. That is why we say we need to strengthen animal identification. Thank you.
Thank you very much. In my view, this should be a priority action. Yes. So then we have a very practical priority action, bring in place a system of animal identification. And I know this is a hell of a job, but you could start with a legislation process, also starting with some groups of animals, for example, bovine. It's easier to start with bovine than to start with goats, because there are so many goats. You could also identify where are the animals, the kept animals. Maybe FAO can help on this. So I would say this could be a priority action. And this will also affect the scoring, because when you have no identification of animals, how can you do a correct surveillance?
Okay, so I just want to respond to the comment on the AMR Committee of Practice. It says AMR Committee of Practice to reduce use, abuse, and misuse of antibiotics in food animals as growth promoters. Now we identify this as a best practice that there is a community of practice. We are not saying that the gap has been taken care of. No, the gap is there. But the fact that there is a community of practice, it means we are putting measures in place to ensure that this gap is taken care of. That is why we have it here, that the presence of the community of practice itself is actually a best practice for us. Thank you.
So to respond to the all-sector surveillance at the, let's specifically at the national level and going down to the subnational level, we have established surveillance systems in public health, animal health, and then the environmental health systems. However, these systems are not interoperable within themselves. That is why we are utilizing the National One Health Risk Surveillance Information Sharing Group to exchange surveillance information between these sectors. So we have established ones, but not interoperable, but then we have some sort of a substitute that we can liaise with each other, communicate, and share information within ourselves. So this is done at the national level, and we scan information within the country and even outside the country. At some of the sectors, we have event-based surveillance systems that picks up threats, public health threats, across all the systems, across all the sectors. And this is what we have currently in place. Thank you.
I want to go to the scoring. Our team is not yet sure that all of your proposed scores are correct, which is not to say that we are disagreeing yet, but we need to look at the evidence and we need to learn more to say. For the second criteria, I believe that your score of 2 is correct and fine. I'm sorry, number 3. The second criteria is correct. I'm not sure that there is enough coordination of surveillance to say that you have scored for a 3 for the first.
5.1.
And we are also not sure, so I'm not sure if this is yet achieved. We want to learn more. And for the third criteria on sanitary animal practices, because of the question of identification in particular, we're not sure if you're yet at a 2. So since this is the first day and we have not had an opportunity to look at your documentation, we want to discuss, and we will have a field visit to an abattoir, and we will learn more before we can agree if these are actually the proper scores. But as Hank had introduced in the beginning, perhaps more important are the actions than the actual scores. Without a doubt, your scores are higher than they were in 2017. You have begun movement that's important, and we see a lot of additional movement to engage in, which we will specify when we will learn more with you.
Very correct.
Are there other comments?
All right, thank you, Prof. So from the other technical areas or other colleagues in the room, are there other comments, observations, or feedback? All right, Prof, it seems the agreement is still in line with what you said.
Yeah. Hank has suggested that I be a little less polite and a little more frank. Unless we can confirm things that you have said, we're suggesting now that the scores to be 2, 3, and 1. We are considering that we do not yet have enough evidence to go with your score your higher scores on the first and the third criteria. I was still a little bit polite.
Any feedback? Okay. Please let's have that. So for clarity,
maybe because of time and the order of the meeting, we are now. We had the time to discuss. Now we are discussing the scores, and now I have to ask to the Nigerian team. The proposal of the external team is to have scores of 2, 3, and 1. Are you in agreement with this or not? If not, I have to send you to a side meeting.
Actually, I think we politely disagree with the scoring. we politely disagree, especially with the surveillance.
Well, we are all polite, and we are all we are among friends, and among friends we also have to have the possibility to discuss.
Yeah,
so,
we wish to discuss that.
So I see there's no consensus at this moment.
Yeah.
I would suggest the team lead and the co-lead and you to go somewhere today to a side meeting and to discuss the scores and to discuss priority actions.
Yes.
And even then, there is a possibility that you are not reaching consensus on the score, but that it depends on the outcome of the field visit.
Okay.
For example, standard operating procedures in the abattoir, something like this.
Yeah.
So I conclude this session on P5 by concluding there is no consensus on the scores. There is not yet consensus on the priority actions. As soon as you reach consensus, you come back to the plenary. Yeah. With this, I would like to thank you very much for your presentation.
Absolutely.
And I would like to thank all.
Thank you so very much, the zoonotic disease technical area. I think we can do better for them for that great job. Thank you so very much. And also to appreciate the external evaluators, another round of applause for them as they make their way. Since Professor Richards is not ready to go yet. Any other comments? I know he's up to something. Thank you so much, Prof, and to the team. Okay, so far so good. I think we have formally come to the end of the first section, and I think Dr. Hens deserves a warm round of applause. The team lead for all the great job he has done so far. Thank you for this great start to this event. So by the way, by the time we're back, please can we have attention, please? Please can we have our attention as we tidy this up? So we have a number of technical areas that needs to come back for feedback. We've only cleared with IHR coordination. So the other technical areas that need to have a side meeting to reach consensus. Hello. Please, can we minimize the other conversation so that we can have attention? Thank you. So we're going to have the other technical areas come back after lunch to give us their consensus scoring and the priority actions agreed. And after lunch, we will be having 2 more presentations. And we'll wrap up today in line with the agenda. So please, we want to appeal that we are all back after lunch into the hall because this is actually the real business why we are here. Lunch will be served for 1 hour, and that will be from 3 o'clock through 4 p.m. The arrangement is the same way we had during the tea break. The tickets have been shared. Please get yours and you can identify where you're going to have your lunch. But before we close, it's my pleasure to recognize very warmly one of the veterans in IHR-related issues in Nigeria, the immediate retired but not tired director of EPID and Surveillance NCDC, distinguished ladies and gentlemen, Please let's welcome Mrs. Elsie Hillary in the house. Woo! I think the applause has said a lot of things. So someone saw Miss Hillary earlier and said, really, there's something about leaving office, about retiring. People look fresher after leaving office. I said, why not if not? Because we keep pushing while we're in the office. And after that, you have less things to push. But actually, there is more time to attend to other things that make life more beautiful. So we're glad to have you in the room, Ma. Thank you for all you have done and all you continue to do. We've also been joined in this room by our very distinguished guests in the academia. We appreciate all our very senior bosses who are observers on the table. Thank you so very much. All the professors, all the head of departments, and all the guests in the room. Thank you so much for being part of this. All right, so officially lunch is served, and we can now proceed. I will be glad to have everyone back by 4 o'clock. Thank you very much. Bon appetit. So please, may I crave our indulgence that we give it all the necessary attention required as we wrap up for today gradually. So for the finance technical area, it's my pleasure to welcome from the Federal Ministry of Finance, Budget and National Planning, Federal Republic of Nigeria, Ms. Onyinye Okoro. Ms. Onyinye Okoro will be the lead presenter for the finance team. You are not clapping and you are in another technical area. Where will you get money? Finance is the warehouse for the fund we need, and I think they deserve more round of applause so that we bribe them a bit more so they could bring more appropriation. All right. She will be heavily supported by Mrs. Habu Ikobeni from the Federal Ministry of Finance again. And from the Nigeria Center for Disease Control, she will be joined by Dr. Itohan Imasuhe. Dr. Itohan, you have to join them. And one critical partner has been supporting this intervention, and JHE generally we must not fail to mention, is Resolve to Save Life. Representing RTSL in this team is Dr. Danjuma Jenom. Dr. Jenom, you have the high table to yourself. All right, thank you, Nigerian team. So now let me hand over the microphone back to the external evaluators for quick introduction. And let's see who we have in the room for the external evaluators.
Make it large.
Introductions. Dr. Hank, we want to introduce ourselves. Sorry.
My name is Henk Ormel. I'm for this technical area the technical lead.
Oh, great.
And this means that my co-lead, Richard, will take the coordinating role that I had before lunch.
Okay.
Good afternoon, everyone.
Good afternoon.
My name is Facia Lake from Liberia.
From Liberia, great. Prof, we know you're ready. So let's move on. So the floor is yours. For this technical area, we have 10 minutes for presentation and 20 minutes for discussion. And the floor is yours. The time starts now. Thank you very much.
Good afternoon, everyone. I'm representing the Federal Ministry of Finance, Financing Technical Area. My name is Okoro Onyinye. Please permit me to stand on the existing protocol. This is our abbreviations and our background. Financial Technical Area has recorded significant progress since the third term JEE in 2019. In collaborating with NCDC, we conducted annual health financing workshop to orient NAP's technical leads on national budgeting process. Resource mapping exercise and identification of available domestic external financing for health security implementation. Then secondly, there is existence of health emergency fund at the national level as part of NCDC Gateway of Basic Health Care Provision Fund, BHCPF, and other partners like WHO, the WBE, World Bank, US CDC, Resolve to Save Life, FAO. And our background, it continues. There's a statutory annual budgeting allocation to MDAs with key responsibilities for health securities. At the federal level, there's availability of service-wide vote for the health security intervention in our national budget. Availability of counter-funding to match donor-funded interventions at national and subnational level, like the Dangote, Bill Gates, state government tripartite agreement for immunization currently going on in Kaduna, Borno, Bauchi, and Yobe State. The country has mechanisms to mobilize private sector resource for health security interventions, like the Coalition Against COVID and the PSHAN. There are ongoing efforts to secure legislative backing for sustainable financing for public health activities, like the establishment of Public Health Emergency Fund, Public Health Emergency Bill 2023, still awaiting presidential assent, establishment of Emergency Preparedness Fund, NCDC Act, Amendment Bill 2023, still awaiting presidential assent. Sorry. Overviews of stakeholders and responsibilities. Federal Ministry of Finance, Budget and National Planning, and other MDAs, including development partners. We have two indicators. The first indicator, P21.1, financial resources for IHR implementation. We chose level 3, and we have rationale to back our choice. The financial planning is based on estimated resources need and a budgetary allocation and or substantial external financing made for relevant ministries and sectors is available to support IHR implementation at the national level. Limited monitoring and accountability mechanisms are in place. So here are the rationales for the score. There is domestic funding for IHR implementation across NAFs implementing MDAs at the national and subnational level. However, the funding is insufficient, particularly at the state and local government levels. Secondly, there is a national monitoring and evaluation framework for budget implementation done quarterly by the Federal Ministry of Finance, Budget and National Planning. Nevertheless, there is need for focused review of budgetary allocation and implementation for health security activities. For the second indicator, P2.2, financial resources for public health emergency response. We chose level 2. And here are the rationale for the score. There are various buckets of mechanism for emergency funding at the national level. Public health emergency funds under the NCDC Gateway of Basic Health Care Provision Fund with the National Health Act. Then we have our service-wide vote for emergency expenditures, also captured in our national budget. Contingency fund for emergency response by partners like Resolving Outbreak Intervention Fund, Redisel, Contingency Emergency Response Component Funds. Through the NCDC BHCPF Gateway, the subnational level will receive some funding for public health emergency operations for emergency response. This is awaiting full implementation. So for the first indicator, we are looking at our strengths. We said there is annual budgetary allocation for health securities across IHR implementing MDAs. There is also a regular NAPS resource mapping exercise done yearly. Substantial availability of external funding, external financing for implementing health securities from the Global Fund, Gavi, WB, USG, and all. Then our best practices, collaborating with the development partners and civil society organizations who advocate for more funding for the health securities. We have our annual health security, annual health security workshop and reskilling of NAPS technical leads on the budgeting process. Availability of direct funding to states through the NCDC gateway of BHCPF for IHR implementation. Then for our areas which we need strengthening, we need to evaluate the NAPS health security to be a priority in the national budgeting process. Also to suboptimal IHR budgetary provision at the subnational level. The fund is insufficient, we need more. Then our challenges. The NAPS and other health security plans, like the National Action Plan for Antimicrobial Resistance, One Health Strategic Plan, are not fully financed. Limited awareness of budgetary process by NAPS technical area leads. Then our strength for the second indicator. Existence of health emergency fund at the national and subnational level as part of the NCDC gateway of BHCPF. We have the existence of our service-wide vote in the budget. Our best practices, public health emergency bill to provide additional funding for health emergencies. This is also awaiting presidential assent. Use of the Rapid Outbreak Investigation Fund as a flexible funding mechanism for timely response of outbreak. Then the last, establishment of health emergency funds by donor organizations, WHO, World Bank, Corporate, and all, to support the national response. Then areas which we need to be strengthened in our second indicator, to facilitate the implementation of emergency funding mechanism for public health response at the subnational level, to streamline emergency funding mechanism by partners and private sectors into the government public health emergency fund. Then where we have challenges, competing national priorities and declining revenue sources, over-reliance on federal government for public health emergency response by states. Then our priority area for action. The first is to develop a framework for monitoring budgetary allocation to NAPS implementation across the technical areas. Secondly is to elevate health security and NAPS implementation into the MTF and national budgeting process. Then thirdly, operationalize the basic health care provision fund, health emergency financing mechanism at sub-national level. Then the fourth one is to streamline emergency funding mechanism by partners and private sectors into government public health emergency fund. There is also need for assent and operationalization of public health emergency funds. Then our reference and supporting documents, we have the annual budget 2021-2023 to 2023. We have the National Health Act 2014, Act 8 of 2014. We have the NCDC Act 2018. We have the review of National Financing Mechanism for Public Health Emergencies in Nigeria, 2021. A report on the implementation of Basic Health Care Provision Fund for Public Health Emergencies by Nigerian Center for Disease Control, 2022. We have the operational guideline for the NCDC Gateway PHCPF. Report of workshop on national validation, reprioritization and dissemination of REMAP 2021. We have our medium-term expenditure framework. All are documented. Then the multisectoral team members are there. Thank you so much.
Thank you very much for this excellent presentation. You made it very clear to reach an ideal level of health security in Nigeria.
Okay, I think it's clear.
Yeah, so I think after the 2017 JEE, we had that exercise done. Right, so from 2017, we had an estimated 134 billion naira, approximately $430 million US to cover Nigeria from 2018 to 2022. And then annually, we have those exercises. So every year, Nigeria develops annual NAPS operational plan, and then prioritize which activities we need to do each year. So that exercise has been done, and we have the NAPS documented.
Okay, thank you. May I ask you to go to the slide with the priority actions?
Priority action slide. All right.
So these are the priority actions you identified. May I ask you, out of these, what is the #1 priority for you yourself?
No, to develop framework.
Operationalize basic healthcare should be.
Okay, so I'll speak for one of the priorities at this moment is to operationalize Basic Healthcare Provision Fund. This funding is actually allocated from the 1% of consolidated revenue from Nigeria, which comes to NCDC through the NCDC Gateway. And a portion of this fund is actually kept aside for public health emergency outbreak response. And the other percentage is distributed at subnational level for the PHEOC's operations through a multisectoral approach in line with the 717 principle. So that's one of the country's priorities right now, is to operationalize the Basic Healthcare Fund at NCDC Gateway. And then the second priority area is to develop the framework for monitoring budget allocation to NAPS, implementation across technical areas as well. Thank you.
Thank you very much. I'm looking to my colleague. Do you have questions?
Right.
I'm looking to the external team.
External team, do we have questions? So we have one here, two. Okay, let's start with two.
Thank you for a very good and detailed presentation. So I have a question regarding your indicator for P201. So you have mentioned that the domestic funding is insufficient, particularly at the state and local government level, which is not unusual. Many countries have this situation. So
I'm so sorry, sir. We can't hear you here. Sorry.
Okay. You mentioned for the indicator P201, you mentioned that the domestic funding is insufficient, particularly for the state and local government level. But given this scenario, I understand that it is vertically allocated fund, the government allocate fund based on your, the local requirement. So given this scenario, the insufficient funding, but I think the score you put is 3. So could you justify that?
We are not talking about scores, we are talking about priority action.
Priority action, yeah. Well, in terms of the local government and the sub-state level, state level, what is the priority in terms of the insufficient funding for the future planning? Thank you.
Can I confirm you get the question right? Not really?
So I'm not really sure we got the question. Maybe can he rephrase it?
Can you help with the question?
More slower now.
My question is the state and local government level. So funding is insufficient. You did mention that. Yeah. So what is the priority action from the, funding is always insufficient. This is the very common scenario. So from your perspective, what is the priority action? Thank you.
Yeah. I think that's better now. Yeah, so I think one, from the priority areas for actions, we can see from point 3 is to operationalize the basic healthcare, which also provide a funding mechanism. And then secondly, there's also thinking on how to actually engage with the subnationals, because Nigerian federal systems, the states are very autonomous and very powerful. So they also have their different budgets. So it's to ensure that we intensify advocacy to the states, which of course now with the new administration, we're seeing that they are also beginning to make health security a priority. So we are hoping that before the next JE, we can be able to make some milestones around that.
So if I could also add, I'm part of that technical area anyway. Let me add that we also have engagement with the Nigeria Governors Forum. That's the governors that operate across the 36 states we have in the country. Health security is now on the front burner of their agenda, and they have the opportunity of presenting these needs on their own regular periodic meetings. From that, we are able to advocate for more resources to support health intervention, security interventions in their state. So I can confirm that also is an additional way to get more funding for them. Thank you very much.
I see there's somebody. Hello.
Okay, thank you. So by extension, I'm part of this technical group as well. We all worked on this presentation together. I'll touch base on the last priority action for the state. So in addition, it's also COPREP, which is one of our health security intervention funds for the subnational, which is a form of a support from the World Bank as well to support the subnational health security activities. So that is one of the priority actions to push forward for that. And in terms of part of the activities that we've done at the national to really look at how we prioritize our budgeting for health security. Dr. Jenom talked about NAPS. We also do what we call the resource mobilization. So we conduct a remap. It's supposed to be annually, but we've been doing it once in 2 years to look at the donors landscape on what are the funding available to us from different sources and how best to reprioritize our activities across different technical areas in addition to the costed NAPS. Thank you. Any other addition from our technical area?
Okay, so we have one more here, Dr. Dalat.
Okay, thank you very much for that presentation, very explicit. So I just want to provide context to the question Hank asked earlier and related to his comments. What determines what amount goes to health security from the budgeting system? So it's a function of what MDAs requested and prioritized in their budget request, as well as availability of resources to fund such. And Genome's response tried to contextualize the fact that in the health security space, we have made a lot of efforts to make estimates prioritized, get our priorities clear, and cost them so that technical areas within MDAs could know what to prioritize when they are submitting to Federal Ministry of Finance during the budgeting process. And hopefully that way, we are going to get more of the activities from the action plan into the budgeting process to make it get approved. So in the same vein, when you go to subnational level also, what is allocated to take care of that gap is a function of availability of resources at that level and the various initiatives she mentioned in her presentation, the Basic Healthcare Provision Fund. All these are initiatives created and passed through the lawmaking process to ensure that certain percentage of the budget is used to address emergency preparedness and response at all levels. Thank you.
Right. Very much. Thank you all for your comments. If we go back to the priority actions, then I can fully agree with these priority actions. I think we have an agreement on this. This is important for you. This brings you a step forward. So we have already an agreement on the priority actions. I was adding another priority action on identifying resource needs, but you convinced me that you are doing this already. And so you know the resource needs, so there's no need to make a priority action because you are doing this through the NEPs already. So if we have these priority actions and if we reach consensus on this, then we have to read with some logic the tool related to the benchmarks, to the scores. And if I go to the scoring of levels of P21, financial resources for IHR implementation.
P21.
Then you are scoring a 3. Financial planning is based on estimated resource needs and a budgetary allocation and or substantial external financing made for relevant ministries and sectors is available to support IHR implementation at the national level. Monitoring and accountability mechanisms are in place. One of our priority actions, where we just agreed upon, is to have a monitoring and accountability mechanism to develop this. This means that when we want to develop it, when we want this as a priority action, I think it is better to stick to level 2, and then you have a 2.5, but if you are not having this monitoring mechanism in place, it is better to have a priority action to put pressure on your decision makers. We need a monitoring mechanism, and then next JEE you will go easily to a 3. So I suppose for P21, A2. Then on the P22, you score yourself a level 2. And a level 2 is saying an emergency public financial resource mechanism exists or is pre-specified that can receive, distribute and use of funds for responding to public health emergencies. But activation and disbursement modalities are cumbersome and untimely. I think this level, you said 2, I think you are on this level. Because level number 1 is saying that there is no planning, there is no identifying of financial resources needed. Funds are allocated and distributed in an ad hoc manner. You are above that. So I really, I'm in consensus with you on number 2. And I have to ask my team, of course, as well. So I would propose to you, for your own sake, for your own good, to, well, we have consensus on the priority actions, we have consensus on this score, but on the score for the first I would say, I would advise you to agree with it too. But I also have to look to my team.
All right.
And they are in agreement, so they support me in this.
All right, so let's check with the team.
So
okay.
my question to you, we reach almost consensus. The only thing is, are you in agreement with my advice to have the indicator on financial resources for IHR implementation at level 2?
Level 2 or 3? Are we in agreement they're proposing level 2 for P2.1?
So I'm not sure, that's from my point, right? So for P2.1, I'm not sure it should be 2, right? So I think really it should be 3 because the rationale here that we are proposing is based on estimated resource needs, right? Which mainly is at the national level, right? And that's what, because budget planning actually does that every year. They review every year budget performance, right? Which all the MDAs are actually part of it, right? So, but I think the gap there, which we have actually, clearly highlighted really, is that it's not sufficient, right? It's not sufficient. But the estimated resource needs, which is the point you are making, is what is, it happens every year. In fact, we do annual operational planning every year, right? Which we project the costs, the cost of implementation of every activities. And then MDAs, ministries review those annual budgets. So by resource needs, again, if I may also ask, so what would that look like really? What does the estimation actually look like? So that we are clear what you mean by the estimation process, right?
Okay, Dr. Jenum, what he was referring to is the limited monitoring and accountability mechanisms, which we put as part of priority actions. So if we are going to focus on developing monitoring and accountability mechanism as a priority action, it means it's not in place. And if it's not in place, that takes that component of level 3 on a question mark.
Okay, so let me build on that. So for the limited monitoring and accountability, really, so the point here is that it's actually been made for all MDS. So the focus now, what everybody wants is that we should have this zoom in for the IHR implementing MDS, which is not clearly on ground now, which is still limited, right? So of course it's a priority. And based on the criteria here, I think that's where it should be. Every year, there is that assessment that is done across, which every government agency is part of it. But what is not in place is that there is none that is available for IHR or NAPS implementing MDS, right, which can tell us at a glance how much really activities, capital projects have been allocated for every NAPS implementing MDA, which we agree with you is something that we need to prioritize. And that's why we actually put it as part of the priority actions.
All right, so Lisdell colleague want to add something?
Okay, thank you very much. I'm aware that there is an accountability framework that was developed by, in partnership, of course, with the NAPS implementing MDAs and, of course, the NCDC, which is meant to be led by citizens and in collaboration with Federal Ministry of Finance and other agencies around the Finance Ministry. Although it's not enough, but at least something is in place. And citizens are actually using that to track budgetary allocation for epidemic preparedness and response, and also releases from those budgetary allocations. I just needed to chip in that. Thank you very much.
So what we're getting from this is that there is an existing monitoring framework. That section says is limited. So can we, pending when we get the evidence in support of this, still allow the indicator, the scoring as it is, or we still want to leave it at 2, and when we get the evidences, we can go back to 3. The decision is yours.
You know, finally, it's for yourself. And if you like more to have a 3 and not this priority action, then we give you a 3 and then skip this priority action. But in my view, the country is better helped if we give you a 2 on this, then we give you and a priority action, then when we give you a 3 and you go back home and you think, wow, you scored a 3,
Yeah.
that is, you are fooling yourself if you do this, to be honest. So I would really advise for the sake of health implementation to stick this to a 2, then the level of trying to get this as a priority is higher than we give it a 3. So I would finally really advise you, keep it a 2. And together with this priority action, you have a strong point to your decision makers and to external funders.
Yeah.
Then go back home saying, oh, we won, we had a 3. But this is not a game. This is not a game of soccer.
No.
So again, and you are the moderator, but I have to look to the team.
Yes.
Again, I would suggest, I only suggest to reach consensus on the 2. If not, we go to a side meeting and then we decide to skip. Are you in agreement?
We can do the side meeting, sir.
Okay.
Side meeting.
Okay.
Thank you.
Okay. All right. I think that will be fine for now. So the team settled for a side meeting to finalize this scoring. And I think that brings us to the end of this section. Do we have the permission of the chair to conclude this section? Yes. Okay, the chair has ruled that we conclude this section. A round of applause for the team. Thank you so very much. Thank you so very much, the finance team. And so we believe that a side meeting that follows immediately with the external evaluators so that they could agree on that area. I can understand the little tweak around it, and it's important we tick the boxes appropriately before we move on. If you don't mind, another round of applause for the external evaluators for this section. Thank you so very much, Professor Richard, Dr. Henk, and the madam for all this great job. So we go to the last presentation for today. Speaking to biosafety and biosecurity technical area.
I will be Hank again.
All right. So let's have the Nigeria team on this conversation, on this engagement. For the biosafety and biosecurity technical area, leading the team and presenting on behalf of the technical area, I have with me from the Medical Laboratory Science Council of Nigeria, Dr. Saritin Hagbolahon. A round of applause for him as he makes his way to the microphones. He will be ably supported by other strong members of the team from the Nigerian Biosafety Management Agency, or national, is it national or Nigeria? National Biosafety Management Agency. Distinguished ladies and gentlemen, please make welcome Dr. Haga Hupai. Dr. Hupai, you have the floor to the microphones. Also from the Nigeria Center for Disease Control, we have Mr. Gariga Dahudu. And last but definitely not the least, from the National Veterinary Research Institute, we have Dr. Sunday Makama. Dr. Sunday Makama, please let's come up stage. Thank you very much. Very strong team and ready to do justice to this discussion. And from the International External Evaluators team, let's welcome the panelists.
Thank you. My name is Geoffrey Jagero, Senior Technical Officer, FHI 360, embedded at the Ministry of Health, Nairobi, Kenya, providing technical assistance on health system strengthening.
Good afternoon. My name is Noor Alam from Australia.
Thank you.
And I'm from the US of A.
The Kingdom of America. All right, thank you, Prof. So we have the floor for the next 10 minutes, the presentations, and the time starts now. Thank you very much.
Okay. Thank you very much. Good evening, everyone. My name is Dr. Sarete Agbolao. I work with the Medical Laboratory Science Council of Nigeria, and I will be making this presentation for the biosafety, biosecurity team, technical area, and will be supported by my eminent team members. Okay. So we look at the overview of biosafety and biosecurity. The implementation of a comprehensive, sustainable, and legally embedded national oversight program for biosafety and biosecurity, including the safe and secure use, storage, disposal, and containment of biological agents found in laboratories and a minimal number of holdings across the country, including research, diagnostic, and biotechnology facilities within all sectors. So we're looking at a cadre of biorisk management experts that have the skill set to train others and establish within their respective institutions, strengthen sustainable biological risk management best practices are in place using common educational materials. So we'll look at a rapid and culture-free diagnostics that promotes, as a facet of biological risk management, safe and compliant transport of infectious substances is also considered according to national and international regulation as appropriate. Just look at the overview of stakeholders and their responsibilities. And we have two indicators under biosafety, biosecurity. The P71 talks about the whole of government biosafety and biosecurity system is in place for human, animal, and agricultural facilities. Under these indicators, our strengths as a country is the existence of a national legislation that regulates biosafety, biosecurity in the country. And that is the National Biosafety Management Agency Act 2015 as amended. We have a national guideline on biosafety and biosecurity. We have an endorsed national integrated specimen referral network, an operational manual in 2020. We also have a national biosecurity policy and action plan 2022-2026. It's a multisectoral plan developed to cover the human, animal, and environmental health. We have a national biosafety emergency response strategy 2020. And we also have the MLSDN guideline on safe transport of infectious and exceptional substances. Under this indicator, some of our best practices is the existence of standardized biosafety and biosecurity templates that we have in some of our facilities, both at the national and sub-national levels. These templates helps to guide biorisk assessment at these various facilities. We also have standardized documentations, standard operating procedures for biorisk management in some of our facilities, both at the national and sub-national level. And as a country, we have been able to carry out audits, of biorisk audits of some of our lab facilities that are in view of biosafety, biosecurity implementation. We also have an ongoing legislation for the prohibition of chemical and biological weapons and to establish a national authority for its implementation. This is ongoing at the National Assembly currently. We have very functional, high containment facilities the Nigeria Center for Disease Control, the NRL, and the National Veterinary Research Institute, VOM. These are operational systems for eye containment. And the approach this country, Nigeria, for biosafety, we are using the One Earth approach, where we conduct training, bringing professionals within the human, animal, and environmental sector for biosafety, biosecurity. We also have leadership commitment from various institutions for the implementation of biorisk management in Nigeria. These have culminated into biorisk policies by APES agencies in the country. And most importantly, Nigeria as a country participates in the confidence building measure. This is coordinated by the National Authority on Biological and Chemical Weapons Convention in the Office of the Secretary to the Government of the Federation. And it is gladdening to note that we have been reporting to the International Committee since 2007, and the last report was submitted in April 2023. On the second indicator, which have to do with biosafety and biosecurity training practices across the One Earth sector, it is our strength in this area is increased biosafety and biosecurity training programs, both at the national and institutional level. And as a country, we have over 84 International Federation of Biosafety Associations certified biorisk manager. We also have others in waste management, biosecurity, and biorisk assessment. We have certified advanced and master trainers that have been trained by the U.S. Sandia Laboratories, supported by the DIPTRA funding. We have 11 certified bioengineers certified by the NSF in country. And we have also been able to carry out a national biosafety and biosecurity situation analysis across the 6 geopolitical zones in the country, doing 76 facilities, and the report has been submitted and endorsed by the Federal Ministry of Health. This was done in 2020. The country has been able to develop a standardized laboratory biorisk management program checklist for risk assessment and biorisk assessment in the country. And interestingly, we have concluded as a country a finalized Nigerian University Biosafety and Biosecurity curriculum. And this was supported by the U.S. Defense Threat Reduction Agency. This document was concluded in July 2023, awaiting institutional operation. Our best practices also have to do with, we have series of trainings on biosafety, biosecurity in facilities handling high consequence agents, and this is on a sustainable basis. And we have also conducted basic and advanced training on biosafety in some facilities in the country. We're looking at some areas that require strengthening under the first indicator. We need to strengthen the coordination of our pathogen inventory, and we also need to have a national coordination for continual audits and classification of our pathogens. We need to support national biosafety, biosecurity risk assessment, and to implement the legal framework and the action plan developed from this. We need more access, we need to strengthen access to occupational health services and to support line agencies to monitor staff competence and standards of training in all laboratories, and the development of a national framework for biosecurity oversight of dual-use research and responsible conduct for scientists, and more fundings for smooth operations of our high containment facilities. We also need to operationalize our biorisk management curriculum and train more personnel on biorisk assessment, carry out regular audits, and train more personnel on biosafety cabinet installation, servicing, and maintenance. and more also to conduct induction and refresher trainings for all laboratory staff on biosafety and biosecurity. On indicator 1, which have to do with the whole of government biosafety, biosecurity system, we are scored ourselves as a country on level 2. And the rationale for this scoring is the existence of a national biosafety management agency, a legislative framework, which is the NBMA Act as amended. And also the existence of the development and dissemination of key policy documents that are guiding biorisk management implementation in the country. Also, the development and maintenance of a functional biorepository for high-priority pathogens. Like we have the National Reference Laboratory in Abuja, the CPHL and the Lagos Biobank. We have the National Veterinary Research Institute in Plateau State. We have the Public Health In Vitro Diagnostic Laboratory in Lagos. And we also have a IHR laboratory here in Abuja. We as a country also have this confidence building measure, which we have consistently submitted to the National Authority on Biological and Chemical Weapons Convention on High Containment Facility, an inventory of high consequence agents. On this note, we scored ourselves on level 2. For indicator 2, which have to do with training, we also scored ourselves on level 2. And the rationale for this is the existence of a situation analysis conducted nationwide that gave an awareness of the knowledge gap in biosafety, biosecurity in the country and the level of practice. This analysis, this document was submitted to the Federal Ministry of Health, and it influenced risk assessment and mitigation actions across the country, which some of us were privileged to participate in. We have finalized our national Nigerian University Biosafety and Biosecurity curriculum in order to enhance knowledge in this area. We have increased training programs across institutions. We have certified professionals. We have trainers in country, and we also have certified bioengineers. What are priority areas for our indicator 1? We want the full implementation of the legislative framework and the action plan. We also want sustenance of the existing collation of the comprehensive record and inventory of our high consequence biological agents in our various facilities within Nigeria. We need to conduct third-party biosafety, biosecurity risk assessment in national laboratories across all sectors. We need to develop a national framework for biosecurity oversight of dual-use research and responsible conduct, code of conduct for scientists. This is very key to us for health security. And there is need to support agencies such as the NCDC, MLSCM, Veterinary Council of Nigeria to monitor staff competence and standards of training at all laboratories. For indicator 2, we are prioritizing the training of more laboratory personnel to conduct biosafety, biosecurity risk assessment. We do not have enough trained manpower in this area. So we need to train more laboratory personnel on foundation and advanced biorisk across 36 states to drive biorisk management implementation, and the need for the operationalization, that is the incorporation of the newly developed biorisk management curriculum into the Nigerian University program under the One Health. And for us to conduct regular laboratory biosafety and biosecurity audit across all sectors. So these are some of our reference and supporting documents. The legislative documents, the NBMA Act, the various guidelines on biosafety and biosecurity, the NISTRA operational manual policy, the guideline on safe transport of infections and exceptional substances, the National Biosecurity Policy and Action Plan, the National Biosafety Emergency Response Strategy, the Directory of Certified Professionals in country, and the PVS Evaluation Follow-up Mission Report of the Veterinary Services of Nigeria, that of 2019, NCDC Guideline for Specimen Transport, Nigeria biosafety biosecurity situation analysis report, and the confidence building measure domiciled in the office of the National Authority. These are the team members, and we say a very big thank you.
And we thank you too. Thank you so very much, the biosafety technical area. Thank you so much. So we're back to the evaluators for your feedback. Thank you.
Thank you so much for your presentation. A couple of comments as we move into the discussion. But first things first, I think your team is lucky because you are the last to present. And so I think technically we could have a discussion lasting 1 hour. So you better be prepared. Number one, the way the IHR tool has been crafted, I'm happy with the language that you have applied in your presentation. And I picked one line that you used, the One Health approach, which speaks to indicator number 1, whole of government biosafety and biosecurity system being in place for human, animal, and agriculture. But having said that, I would like to you and your team to probably shed light for us on this NBMA Act and Plan 2022 to 2026. Exactly what does it address? I know we might get to a point where we'll request probably for that document as evidence. We want to prove that it actually speaks to this core capacity. As you prepare on that, to respond to that, number 2 is you have alluded to several trainings that are going on, planned, are going on, and others that are yet to be implemented. For example, they just approved curriculum for universities. My question to your team is, does the country have a harmonized biosafety, biosecurity training curriculum for in-service personnel? And then 2, I think Nigeria is the second country I know in Africa that has just developed biosafety, biosecurity curriculum for pre-service universities and colleges. And I think that is commendable because it also speaks to the aspect of sustainability.
A round of applause for us. That's great.
Sustaining this core capacity has not been easy in most African countries or low-income economies because it's very important, it's very difficult and costly in terms of resource allocation for trainings. So one of the sustainable measures that we advocate for is for countries to develop pre-service training curriculum and implement it as soon as you can. It serves 2 purposes. One, it's easier to sustain by training people and introducing them to the concept pre-service. And 2, you begin to build a critical mass, a large pool of life scientists who will be your champions in biosafety, biosecurity, dual-use research of concern, and I think the emerging area of cyber biosecurity. So I'll stop there and let you respond to some of the issues that I have raised as we move on. Thank you.
Okay. Yeah, thank you very much. First of all, I will say that if Nigeria gets it right, other African countries will also get it right. And many African countries have been coming to Nigeria to learn from us how we do it here, biosafety and biosecurity. Last week, Burkina Faso just visited MBMA. Last 3 weeks, South Africa visited MBMA. Last month, we visited India to see how they are doing it, biosafety, biosecurity. Now, the National Biosafety Management Agency was established with MBMA Act 2015 in 2015 to regulate modern biotechnology, ensuring its safety to human health, environment, and plants. Because we are doing a good job, in 2019, the MBMA Act was amended to include the regulation of gene editing, gene drive, synthetic biology, and putting in place measures to ensure biosecurity in Nigeria. Now, I'm going to the question you asked, which is the policy, National Biosecurity Policy and Action Plan 2022 to 2026. It is when this amendment was made and we were given also the power to ensure biosecurity in Nigeria that this act, or we develop a National Biosecurity Policy and Action Plan 2022 to 2026 with other stakeholders. And this action plan has about, chapter 1 of the action plan talks about the introduction. Chapter 2 talks about the policy statement, policy thrust, policy mission, policy vision, policy objectives. Chapter 3 talks about the area of focus, the institutional governance. Chapter 4 is what we are talking now. That is the action plan. This action plan, and this action plan, that is chapter 4, has about 24 thematic areas, talking about human health, plant health, agriculture, environment, bioterrorism, biothreat, all together. It's about 24 thematic areas. If you go to our website, you will get everything about it. Yeah. So all now,
right. If you don't mind to help summarize the response so that you can.
To summarize it, this action plan, which has been approved by the federal government, we have also had a stakeholders meeting this year, which we established advisory council, biosecurity advisory council, and secondly, we established national technical working group, which needs now implementation. So we are now talking about the implementation of this biosecurity policy and action plan 2022 to 2026. But since there's no time, I could have continued to talk about this fantastic policy.
Absolutely.
Thank you.
Thank you very much.
Thank you. Thank you so much.
No, I'll answer that last one.
Do you want to respond to one of the questions I asked?
The other question?
Yes.
The in-service. We are glad to report that as a country, we sat in 2020, all the expert stakeholders. We have the Nigeria Biological Safety Association. And that year, we were able to do this using the ROSSH grant, coordinated by the MSH. We were able to develop the Nigeria Biological Risk Management Curriculum for in-service training. We domesticated and make some local adjustments using the Global Biorisk Management Curriculum, which is housed by the Sandia National Laboratory and other international stakeholders within the US. So we sat as a country in 2020, and we developed that. And since then, we have used that harmonized curriculum to train personnel in the different sectors, both in foundation biorisk management and advanced biorisk management implementation. For the pre-service curriculum, I will ask Dr. Bakama to speak to that. Thank you.
And you get 1 minute because we're over time.
Allow us to answer your questions.
Allow you to go home.
Thank you so much. Maybe all I will just add is that for those of us in this space, we should be aware of the ISO 35001, which is the first ISO standard also that has to relate to biosafety and biosecurity. And most of these documents and training materials are structured to take that into cognizance. So in our curriculum development for the institutions, we have a consensus document that has been drafted and adapted and adopted to the Nigerian setting, which hopefully, once it's been rolled out, all the universities will be able to use a harmonized, standardized, quality-checked curriculum and material. Thank you.
Thank you very much. I would wish us to move to the priority areas and look at them briefly for consensus building.
Because that's where they are interested in all this. Okay.
Thank you so much. So I think the first bullet is part of the explanation that you have just provided, the team has provided. And my question to you is, are you satisfied with these priority areas, priority actions that you have developed? In your opinion, are you satisfied that within the next 5 years from this year, these areas, when addressed, will move and push Nigeria forward from the scores that we are seeing today, which we, of course, we are yet to agree on, to a higher level of compliance?
Yes, we are satisfied, but we welcome addition from any other source. Hopefully, we do believe and we strongly hope to see an improvement if these priority areas are attended to.
Thank you so much. What I did tell you is when you were presenting your priority areas, I felt like you stole my ideas or you stole the words from my mouth. So,
Maybe you were trying to steal their ideas.
So I would like to ask if there are any comments from my colleagues, the technical experts bench.
Are there feedbacks? Are there comments from the external evaluators? Okay, we're in agreement.
Okay.
And to the general technical areas in the room, any feedback, any comments, observations? Okay.
Okay, so we can move to the scores and so on the indicator P7.1, whole of government biosafety and biosecurity system is in place for human, animal, and agricultural facilities. You gave yourselves a score of 2. And based on the body of evidence that you have presented here, the explanations that you have provided, and the efforts that you have put at the country since 5 years back, I want to agree with you that this technical area indicator deserves a score of 2. Do you agree? Let's move to 7.2.
7.2.
Again, on biosafety and biosecurity training and practices in all relevant sectors, including human, animal, and agriculture. I want to agree that the score of 2 should stand, but there is a caveat. If you go to your priority actions, they are not so clear as to whether some of those actions are whole of government. If you're going to talk about trainings, if you're going to talk about risk assessments, one, they should be joint across all sectors, because the experience is that we in the human health sector, we tend to leave behind environment and animal sector. So we need to be very clear, and that should be articulated on those priority areas. So you can play around with the wording to let that come out very clearly. Do we agree on a scale on the score of 2?
Yeah.
Yes.
2.
Thank you.
Thank you.
So we close this final session of today with agreement and further elaboration of the action points. It's a good way to end, and let's not make the end last forever. Let us end.
Thank you very much. A round of applause now for the biosafety, biosecurity, technical areas. They take a bow for the great job done. And they wouldn't have to go for a parallel side meeting. Thank you very much. And to the team of external evaluators, and every one of us, so far so good. A wonderful round of applause for ourselves. Thank you so much. I wouldn't know whether they want to have the comment first. Okay, just take over from here.
No, I think first we need to know if there is any level of agreement.
Okay, with the side meetings.
The side meetings.
Okay.
So we are still waiting for AMR. AMR, who can report on the side meeting of AMR?
So AMR. Did you agree?
And biosafety, excuse me, finance, I know because I was the technical lead in finance. On finance, can you come here, please? Yeah, of course. You have something nice to say about finance. We have it together to say.
Yes. Okay, so on behalf of the finance technical team, we've agreed for indicator P.1 to choose the indicator, to choose 2.
So we're on level 2 for that
2.
indicator.
Yes.
As I just said, thank you very much. And then antimicrobial resistance. Antimicrobial resistance.
Ladies first.
Okay.
Thank you. So for AMR, the evaluators agreed that we remain on level 4. We were able to show the documentation that was required, but we were asked to finalize the NAP 2.0 as soon as possible, and also we agreed on priority actions.
Okay. Thank you very much. Professor Richard, do you have any comments? As said, thank you very much. Any other one? I think those are the 2 technical areas. Okay, IHR too. Okay, zoonosis. Okay, for zoonosis, can we have the lead?
Zoonosis.
There were 3 indicators for zoonosis.
Hello.
My veterinary colleague is coming.
We had the team was concerned that the score of 3 was too high, but in our side meeting, they have convinced us.
Sorry, bro. Please, a section is still ongoing. The discussions are not okay for now. Please, can we hold on? We're almost done. Thank you.
We have agreed provisionally in a score of 3 for the first indicator for zoonosis, awaiting evidence. The second one we already had agreed. And the third indicator on the abattoirs, which the team had suggested was 1, the Nigerian team agrees it is not a 2, it is a 1. So we are nearly in agreement.
Nearly in agreement. Dr. Nasir? Okay. All right. So let's appreciate the zoonotic technical area. Thank you very much. And IHR was the first one. The agreement has also been earlier resolved. But Dr. Enk, before we have your closing thoughts for this section, we'd like to hear from our observers. What are their thoughts about the whole proceedings today? Just 1 or 2 comments, if you don't mind, after which you have the floor to get the last thoughts on this conversation. So for a panel of observers, do we have any thoughts on how far so far?
Just some closing thoughts. There's a consensus to have Professor Adebi and Mrs. Ilori. All right, Prof.
Okay. Good afternoon, everyone. Oh, it's good evening, actually, because we're already in the evening. I think I really want to commend the team. They have done so well. And I'm happy that we're agreeing with our external evaluators with some of those areas, because if we really look critically, we don't need high score and tell ourselves that we are where we are not. And at the end of the day, the policymakers will just say, oh, we've done so well, and be praising themselves, while we're the ones that will be suffering, because they're the ones that are supposed to give us what we are expected to use to work. So when we score ourselves so high, and at the end of the day, we are really not there, we are really shooting ourselves on the foot. So I want to appreciate everyone. They've done so well. We've observed, and I think the presenters really presented well, especially this last presenter. I think they were so confident, you know. We were so, we thought they were not going to even have any arguments at all. So we really appreciate the presenters were well, you know, they presented so well. I want to thank our external evaluators. They were very, very critical and very they were not biased. They looked at it critically, and I think because they were trying to support us and help us to really move on. So I want to thank you. You have really done so well. Thank you. And thank you to our team lead. He really, he coordinated it so well. So while we were discussing here, we said, the external evaluators, our team lead is really a team lead. Thank you.
Okay, so the team agreed, and there's also agreement at the panel of observers too, that they have all done well. Thank you very much. A round of applause for ourselves, and you have the floor for the closing thoughts.
Thank you very much. Nigeria, thank you. On behalf of the external team, we reached agreement on 5 of the 6 technical areas, and on number 6, almost. And this is quite unique. Sometimes it takes days before we reach agreement. But Nigerians are people, you need to talk, you need to discuss, but you can also decide. And that's what I really like in you. Thank you so much. And I would like to finalize, because we all want to go back home, I would like to finalize because we have been applauding ourselves, we have been applauding the teams, we have been applauding almost everybody. We must not forget the technical people who make this all possible. Let's give them an applause. We must not forget the people from the hotel. Excellent food, excellent service.
Thank you very much.
And finally, we should almost forget, but we cannot forget our moderator. Thank you,
Thank you, too.
This is it for today, for me.
All right. Now, what do we give to the team lead himself? A wonderful round of applause. Absolutely, and you agree with me. It's been a great start here today, the day 1 of 2023 JEE for Nigeria. Tomorrow is going to be more exciting. You don't want to miss it. Activities commence 8:30. Please, let's be here as much as early. And we'll be taking another round of technical areas, and we'll take it up from there. From me, good evening.